ممنوع تاخد أجازة، ما ينفعش تشتغل من البيت، ممنوع تعزل نفسك، مطلوب منك تختلط بالمرضى، تستنى الخطر في كل لحظة. لكل طبيب في مصر والعالم بيخاطر بسلامته وأمانه علشان حياة ملايين بيواجهوا خطر وباء كوفيد-19. كلمة شكرا مش كفاية. احنا في نوفارتس مش بس بنشكركم، احنا معاكم، بنشارككم ونشارك العالم كله بإسهاماتنا في جهود مكافحة كوفيد-19 عشان ننفذ التزامنا الدائم بتمكين ودعم المرضى. مش احنا بس، كل فرد في العالم بيدعمكم عشان تنجزوا مهمتكم. كل واحد قرر يشتغل من البيت، كل واحد بيحمي نفسه وغيره بالعزل الاختياري، كل واحد بيتجنب الاختلاط، كل واحد بيبعد عن أي مصدر خطر ولو محتمل، كل واحد بيحافظ على العادات الصحية. كل دول بيدعموكم وبيشكروكم وبيتمنوا لكم السلامة.
Good evening. أهلا وسهلا بحضراتكم. النهارده مشرفينا في virtual conference of the Arabic Association for the Study of Diabetes and Metabolism, member of International Diabetes Federation, and this virtual conference is sponsored by Novartis. So we appreciate a lot the cooperation with Novartis. This meeting is having very high caliber speakers from more than one place outside Egypt, international speakers, and also eminent professors from Egypt. We are working for 2 days, today, Wednesday, and tomorrow, Thursday, and we are going to start also tomorrow at 8 p.m. Today we are having 5 presentations. Let me start with the agenda. Professor Franz from Denmark. Professor Franz is an eminent professor of medical psychology, and then we are having Professor Muhammad Hassanein from UAE, Dubai, and UK, and Professor Muhammad Nasrallah, which is a professor of nephrology in Cairo University, and Our Lady of Cardiology, Professor Jamila Nasr, a very dear friend, and she's the professor of cardiology in Swiss Canal University. Again, thank you, Novartis, and I'm also giving appreciation and gratitude to those who are attending the meeting today. And let me start with Professor Franz. Professor Franz is a professor of medical psychology, Southern Denmark University, and he's going to talk about how to keep your patient psychological health. Professor Franz?
Yes. Good evening, everybody. I would like to thank the organizing committee for inviting me to give this talk about psychological factors that matter in diabetes care. My name is Frans Pauwer and I'm affiliated to the University of Southern Denmark and also to Steno Diabetes Center Odense. My background is a background in medical psychology, and as a medical psychologist, I'm purely specialized into diabetes. There are many psychological problems that are relevant for clinicians who work with people who have diabetes. And these problems can be diabetes specific, so only people with diabetes have these psychological problems, or generic. And some examples of diabetes specific psychological problems are, for example, not accepting diabetes, worrying about complications or having to cope with these long-term microvascular or macrovascular complications, problems with motivation to take care of diabetes or diabetes burnout. Fear of hypoglycemia is another psychological problem that is quite common, and we have received 1.7 million euro from the EU to look at the impact of hypoglycemia also on quality of life. So that is one of the studies that we are conducting in Denmark right now under the framework of the HypoResolve study. Hypoglycemia unawareness, fear of self-injecting, of course, is a problem we should consider in clinical practice. It is not a very common problem. So many people who start injecting themselves are afraid of the needle, but the fear goes away often quite rapidly. But approximately 1% of the people with diabetes have a very high fear also after months of using insulin injections, for example. Fear of self-testing is often associated with fear of self-injecting, and negative perceptions regarding insulin therapy are also a psychological phenomenon that we have studied, and that occurs in many people with type 2 diabetes who are not using insulin yet. There are also psychiatric problems that occur in anybody that can also make it more complex to take care of diabetes. These problems are, for example, depression, anxiety, sleep disorders, and eating disorders. So imagine that you have type 1 diabetes and you struggle with an eating disorder like anorexia, and you have the idea that you are overweight and that you should lose weight. Then there's an easy way to get rid of some kilograms just by skipping your insulin injections. But we know that young people who do that often have complications in their early 20s. So that's also a very important psychological or psychiatric problem to study. Sexual problems or problems at work or marital problems are also studied by psychologists with a link to diabetes. But today, I want to emphasize that these problems are not only common, they can be a very important barrier that also hampers good diabetes self-care and leads to suboptimal glycemic control and future complications. To illustrate that, I will focus on depression. That is the best studied psychological problem in diabetes. I'll share some data with you regarding the prevalence of depression. I'll share data on longitudinal studies with multiple assessments. Then I will share information with you regarding the impact of depression in people with type 2 diabetes. In which way does depression impact health outcomes in people with type 2 diabetes? Then the mechanisms will be discussed. And last but not least, I will end this talk with also what we can offer to people with diabetes who suffer from depression. So there are good solutions also on top of medication. So if we look at the symptoms of depression, we can see that we're not talking about a light disease. Depression is a severe psychiatric condition that has several symptoms, and the two symptoms that are on top of this slide are, of course, the key symptoms: depressed mood that is out of proportion to any cause, and the inability to enjoy life. Then another symptom involves changes in weight, and that can be losing weight or gaining weight. So gaining appetite and eating more, or not being able to eat. Sleep is impacted by depression, and also the way people move. So some people slow down, whereas others become so restless that they cannot sit still anymore. Many people with depression have excessive feelings of guilt, guilt in general, but it can also be guilt related to not being able to achieve good glycemic control with your diabetes, for example. Suicidal thoughts are common in people with depression. Problems concentrating and finding it very difficult to come up with decisions. And last but not least, fatigue is also a very common problem in depression, and it's a symptom of depression. These symptoms should cause clinically significant distress and impair people's social, occupational, and other important areas of functioning. And it should not be attributable to substance abuse, for example, or to another medical condition. We know from lots of studies that depression can be considered as a very common complication of diabetes, and that can be either type 1 or type 2 diabetes. So if you look at this slide, you can see on the left side the result of studies that have used a diagnostic interview to diagnose depression. So that is the gold standard to assess whether people suffer from a psychiatric condition. On the left side, you can see that 5% of the people in the general population suffer from major depressive disorder, whereas 9% of the people with diabetes were diagnosed with depression. And on top, you can see that the odds are 1.9 higher than the controls. So that means almost 2 times higher. If you go to the right side of this slide, you can see that 26% of the people with diabetes had an elevated depression score. So that's also 2 times higher, approximately 2 times higher than the controls, where it was 14%. These studies did not rely on diagnostic interview, but on self-report measures of depression. So it is a common problem in people with diabetes. This means that if you translate it to your clinical practice, that if you treat 10 people with diabetes a day or in a week, that 2 of them have to cope with depression. One is suffering from a major depressive disorder, has a psychiatric disease, and one has a subthreshold depression. If we translate this to a global problem, then it means that there are more than 40 million people worldwide who have both diabetes and a comorbid depression, a major depressive disorder. So we're talking about a big problem, also from a global perspective. When I was a young postdoc researcher, I was really interested in the impact of complications on depression prevalence. And what I did is I compared the rates of depression in people with no chronic disease with those who had type 2 diabetes only. And what you can see in this slide is that 9% of those with no chronic disease had an elevated depression score compared to 8% of those who had type 2 diabetes. The odds were not increased if people had type 2 diabetes only, but the odds were increased if they had type 2 diabetes and complications of the disease. Then almost 20% of that group had an elevated depression score. So this means that it's not only having type 2 diabetes, but also having to cope with complications of the disease. This is a slide showing the design of the DAWN2 study, a very famous study that was conducted in more than 15,000 participants worldwide in 17 countries. And what was really interesting is that they did not only focus on people with diabetes, but also on family members and on healthcare professionals and people with type 2 and type 2 diabetes, type 1 and type 2 diabetes, sorry. In that study, they did not only look at well-being scores with the WHO-5 questionnaire, but also on levels of diabetes distress. And on average, 40% of the people with diabetes reported an elevated level of diabetes distress. There were considerable differences between countries. So in some countries, the rates were a bit lower, but it was an issue in every country. We also know from many studies that diabetes distress is quite common in people with depression. And we think that if people become depressed, if they have diabetes, they will also often suffer more from the diabetes. But if they get more stress from the diabetes, it is also more likely that they develop depression in a quicker way. So the relation between diabetes distress and depression is probably bidirectional. So I think that having type 2 diabetes will lead to microvascular and macrovascular complications, and the burden of having a chronic disease that you have to manage with oral medication or with insulin, and the distress that comes from having the disease can contribute to depression, on top of other life stresses that people can have, marital problems or work-related problems or financial problems. So a couple of years ago, we also wanted to know that whether having type 2 diabetes is also associated to a higher risk of developing a new depression. And in this meta-analysis that we conducted together with Ari Nouwen, we found that that is the case. So people with type 2 diabetes have a 24% higher risk to develop a depression in the future. A good question that clinicians can ask themselves is, what is the very best predictor of depression in my patients with diabetes, or the people with diabetes that I treat? And the answer comes from this study. So if you look at the results of the post-op study, this study had 3 assessments in 2005, in 2007, in 2008. And we found that a high depression score was visible on at least one assessment in 26% of the participants. 14% of the participants had an incident depression, so these were to be considered as new cases of depression. But what was really an important finding is that 66% of those with a high depression score at baseline had a high depression score either in 2007 or in 2008. So that means that a high depression score in the past is the strongest predictor of a depression in the future. So if you know that your patient was ever treated for depression or anxiety, you should follow this up and ask about it also in new meetings, because it is a very important barrier that's for proper diabetes self-care. This is a picture of Thomas Willis, a very famous English physician who noted that the urine of people with diabetes tasted sweet. That was one of his observations. One of the other observations that he noted down was that depression was more common in people with, diabetes is more common in people who had suffered from melancholy or a period of sadness, long sorrow. And a couple of years ago, in 2006, we published a meta-analysis testing that hypothesis that Willis already put down in one of his books ages ago. And we had to admit that Willis was right. So people with depression have an elevated risk to develop type 2 diabetes, and that risk is 37% higher compared to controls who are not depressed. So the association between depression and type 2 diabetes is probably bidirectional. Type 2 diabetes leads to a higher risk to develop depression, but the reverse is also true. In this slide, you can see that depression is also associated with a higher risk for mortality. This slide is showing 4 different groups. And on top of this slide, you can see that the group without diabetes and without depression lived the longest. Mortality rates were higher in those with depression only. And this is the group with only diabetes. And this is the group, lowest line, where people had both depression and diabetes. After 10 years, almost 60% had passed away, died. And this is adjusted for differences between these groups. So it's adjusted for age, for sex, and baseline complications. So we also conducted a meta-analysis and compared a lot of these studies. And we concluded that depression is associated with all-cause mortality in people with diabetes. So depressed patients with diabetes have a 46% higher risk to pass away. And for cardiovascular mortality, this was 39%. So as researchers, we have a big challenge to investigate the mechanisms that link depression with type 2 diabetes. And there are many candidates, but a very important one is poor glycemic control. We know that depression is associated with a higher HbA1c. And that is, of course, a very important risk factor for future complications. We know that self-care of people with diabetes is less optimal. So we know that appointment keeping is less optimal in depressed patients with diabetes. The diet is less optimal. Medication taking is less optimal. They exercise less. And also their glucose monitoring is less optimal, as shown in this meta-analysis published by Gonzalez et al. In Diabetes Care a couple of years ago. Other potential mechanisms could be alcohol abuse, increased smoking, poor sleep quality, dysregulation of the stress axis, or higher BMI. Sorry. We know, for example, that visceral adiposity is more likely to develop if people are depressed. Certain inflammatory markers are elevated in people with depression. A higher level of oxidative stress could play a role. And we also believe that genetic factors could play such a role as common denominators of both type 2 diabetes and depression. Now, a little bit more information about the treatment of depression in people with diabetes. So Van der Veld, Cornelis et al. Published a meta-analysis of 14 randomized controlled trials that studied whether depression in people with diabetes can be treated. And the answer is yes. And they found the largest effect for psychotherapeutic interventions. And usually these interventions consisted of cognitive behavioral therapy. And I'll tell a bit more later on about that. Depression can also be treated with medication, pharmacological treatments, and there the effects were moderate. And what was found is that sertraline also lowered HbA1c. Collaborative care can be used to treat depression in people with diabetes. And I'll tell a little bit more about collaborative care in the next slide. A very big clinical problem is that there is an underdetection of depression. And because of the underdetection, there's also an undertreatment, and that underdetection and undertreatment is approximately 50% to 60%. So those who go to the doctor with diabetes and major depressive disorder are not recognized as such as being depressed in 50 to 60% of the cases. Thompson et al. Thought, well, let's re-educate primary care physicians and learn more about what depression is and how it should be recognized and treated. They conducted a randomized controlled trial to see Whether that worked, but the answer is no. That is not beneficial. Physicians know what depression is, they know how to treat it, but often in clinical care, time pressure is huge, and it is often not discussed. That is often the case. That is my take of this study. We also studied recognition rates in the Netherlands by nurses who were very interested in psychology, actually. And we found that those who had a high depression score, only in 25% of the cases, the nurse noted down that there was any psychological problem. It could be a note like patient is stressed, or patient doesn't feel well, mentally well, or patient feels depressed. That was counted as a recognition. So only 25% in the Netherlands. In 1994, the St. Vincent Declaration recommended that the psychological well-being of people with diabetes should be monitored, like we monitor HbA1c. And we tested that in a randomized controlled trial. So the control group received standard diabetes care, and the intervention group received standard diabetes care and monitoring of their emotional well-being. So they completed a short questionnaire, and the score was discussed with the nurse in an open discussion. And we found that in the intervention group, approximately 20% of the patients were referred to a medical psychologist, and that could lead to many different conversations. In some conversations, it was a major depressive disorder was diagnosed. In other meetings with the medical psychologist, the patient explained that he or she had lost an important person and was mourning, but also that there was no need for psychological support, that there was a lot of support from family members and from friends, and that that person considered the stress and the depressed feelings as part of life. So in the end, we concluded that the emotional well-being was better in the intervention group after 12 months, and that they were also more satisfied with the care provided by the diabetes nurses. But we found no impact on HbA1c in this particular study. Then the famous study from the USA, which is named the Pathway Study. And stepped care in the Pathway Study, an important element is monitoring of emotional well-being, and then offer stepped care. First starts with a light intervention where people have to read or go to a website to learn more about depression and kind of self-treat it. And then step by step, intensify the treatment if the symptoms are still there. That worked well in the Pathway Study, so that's published in the Archives of General Psychiatry. So the intervention group did better than the control group. But what is also very interesting is that the financial impact of a successful depression intervention was also quite big. So the net economic benefit of this depression intervention was almost $1,000 per patient, because people with successfully treated depression went back to work way earlier and consumed less healthcare. So this is a famous study conducted by Pat Lussman, and he studied whether we can treat depression in people with diabetes with cognitive behavioral therapy. And in cognitive behavioral therapy, people learn to think differently in a more rational way, in a more helpful way about themselves and about life or about diabetes. And more than 80% of those who were treated with CBT had a remission of depression compared to 30% of the control group. And even 6 months post-treatment, 70% was still not depressed anymore compared to still 30% of the control group. So this is an effective way of making people stronger, being able to cope with depression and get rid of depression symptoms, also in people with diabetes. We also tested a web-based CBT therapy program a couple of years ago together with Frank Snook, who developed this. And we found that this is possible. You can also treat depression with online therapy these days. So there's no need to go to a psychologist's office. People can also self-treat it at home behind their computer and do some homework and learn more about their symptoms, how to treat it. So we published that study in Diabetes Care. And we also found a decrease in diabetes-specific emotional distress in this study. But again, HbA1c stayed the same in this study. Another way of treating, so that's a third way on top of medication of treating stress and depression in people with diabetes, and that is mindfulness-based therapy. So in CBT, people learn to think in a more rational way and change their thoughts. In mindfulness therapy, people learn to just observe their thoughts and relax. Also to plan experiences in their life where they focus on really what they're doing. So go out for a walk and try to focus on the present moment and walk or eat a nice meal. So live a more mindful life, so to say. And that was also a successful way of reducing stress and improving quality of life and reducing depression in people with diabetes. That is shown by this randomized controlled trial. I'd like to end with these conclusions. So we know that depression is common in people with diabetes. We know that it is a risk factor for type 2 diabetes and its complications, and that people with depression and diabetes die a couple of years earlier. So it's a very unfavorable combination. At this stage, we do not know whether successful and intensive treatment of depression prolongs life in people with diabetes. That's currently unknown. That's not really well studied. The mechanisms are also understudied. So we need new studies where we really focus at the biological mechanisms and also the behavioral mechanisms that could link depression and diabetes. And in these studies, we could also focus on subtypes of depression, atypical depression or melancholic depression. It could be really relevant. I also think that many countries need more well-trained medical psychologists to conduct this research, but also to work in the hospitals and support the endocrinologist and the nurses to treat the psychological problems in patients with diabetes, and of course also in primary care medical settings. We also need a master training at universities in medical psychologists in many countries. And psychological factors should also be incorporated in the training of nurses and doctors, of course, because they're so important, because diabetes care is self-care. And the last conclusion is that depression in people with diabetes can be treated by medication, of course, with CBT, mindfulness-based cognitive therapy, and with stepped care. So thank you very much for your attention. Are there any questions?
Okay, thank you very much, Frank. It's a very clear presentation. Let me go through, there's some questions. I invite you all to write your questions, or even the faculty, if they have a specific question, they can mention it or to write it for us. Perhaps we can take the first question, Frank, about the role of the psychotherapy versus antidepressants. I saw from the questions people asking about when would you use psychotherapy, when would you use an antidepressant, and which antidepressants would you use?
Yeah, all people are different. So some patients will have a preference for medication and others not. So I think it's also dependent on patient characteristics. And then I'm not a psychiatrist, so I think I should refrain from giving specific advice regarding medication. But we know that several different medications have been tested in people with diabetes. Personally, I think that the psychological interventions are not only treating symptoms, but can make people stronger. So if you learn from a nurse or from a psychologist or from a doctor to cope with problems in life through CBT, or if you learn to relax in mindfulness-based cognitive therapy, you're becoming a stronger person. Stress is a normal part of life, but if stress levels become too high, then they can impact our brain and can make people, in the end, depressed. So personally, I would recommend psychological care or psychological treatment as a first step. But of course, if people are severely suffering and suicidal, then antidepressant medication can certainly have a very important role. So,
okay.
Like fluoxetine, sertraline, or
I mean, the presence of psychology support is quite strongly recommended in many places. Unfortunately, it's very much underused. There's a question here about when would you consider in a newly diagnosed teenager the psychological support?
I think every diabetes team that is treating young people, but also that is treating adult people with either type 1 or type 2 diabetes, should have a psychologist on board. Today, I've been talking about depression, but you also have people who are suffering from an eating disorder, for example, and that's a bad combination if you also have diabetes. We know that sleeping disorders are very common in diabetes and are associated with poor glycemic control. So psychologists can strengthen the medical team and sometimes find solutions how to approach a patient in terms of therapy, but also to treat psychological problems. That would be my recommendation.
In your presentation, you clearly shown the bidirectional link between depression and diabetes.
Yes.
So in people with diabetes, we are very frequently missing the signs and the symptoms of depression.
Yes.
Should we adopt in our daily practice like a depression risk questionnaire or certain things to detect the person with not the bang door depression symptoms or signs?
Yeah, if you look at different guidelines, for example, the guidelines from the ADA or the guidelines in the Netherlands or Germany, or ISPED guidelines for young people with diabetes, they all recommend monitoring of emotional well-being, including depression, but also disturbed eating. I think for the medical team, it is good to be aware what is going on in the mind of the person with diabetes. And a high score should be discussed, so should not be regarded as a diagnosis, of course, but as a way to quickly get to know the person who has diabetes. So these psychological problems can really be a barrier. What I realize is that it is time consuming. So the challenge is to do that in a smart way. But if we use smartphones, for example, to do the assessment, so patients can already complete it at home. And if we do it in such a way that the physician already has the scores in the patient chart, then physicians and nurses need a small training how to discuss this course, and of course be able to refer. If you recognize depression and you cannot refer a patient to a psychiatrist or a psychologist, it becomes unethical.
Or maybe we can use the negative point of patients waiting to get to the clinic room, do the assessment, and convert the negativity into something positive for the person to self-assess themselves, and then we can end up with the risk score.
Yes.
Let me just go through some of the questions.
Yeah.
I guess with the COVID era, you cannot avoid the question of the stress related to COVID disease, specifically in people with diabetes. Any quick points on this?
Sorry, I missed that question.
The people are asking about the mental stress in diabetic COVID in the era of COVID-19. Yeah,
there is an interesting publication in Diabetic Medicine. Jane Spate is one of the authors, together with Timothy Skinner. But I did not have the opportunity to read the paper. But my impression, when I look at different websites of people with diabetes, is that it is a strong concern for many of them. People with diabetes are probably more vulnerable for the virus, so the virus can have a more negative impact. So what I expect is that the stress levels are higher in people with diabetes related to COVID.
Frank, you've alluded that you're not a psychiatrist, so you didn't want to commit yourself to discussion about the pharmacological agents for antidepressants. Mm-hmm. There's a question, maybe you can just reflect on it, can we depend on the likes of duloxetine that people use for diabetic neuropathy to treat depression as well? Or, yes. Or amitriptyline that sometimes people use? Yeah. Would that be enough? Or, treat neuropathy and treat depression at the same time? Or what would be your reflection?
Yeah, well, we know that duloxetine is also registered as an antidepressant medication. So my take of it is yes, that should be possible. My impression from clinical practice is also that many psychiatrists try different medications and see whether they work. So if a certain medication does not work, then they try another medication. But I'm not sure whether there is a certain sequence for people with diabetes, which medication should be used first. I'm not aware of that. I've never seen that.
Sure. Any questions from our co-faculty, if they have a question for Frank before we move on to the next part?
Thank you very much. Thank you.
My pleasure.
It was a brilliant discussion. Thank you.
Thank you.
Thank you very much, Frank.
My pleasure. Thanks for having me.
Okay, so now we'll move to the next presentation, and it's my great pleasure to introduce a very dear friend and colleague, Professor Ines Shaltut. I don't think anyone in Egypt who is interested in the field of diabetes doesn't know Professor Ines, a professor in Cairo University and the president of the Arab Association for the Study of Diabetes and Metabolism. And today, Professor Ines will cover the very important discussion about the intensification of treatment, whether we start with monotherapy or dual therapy as the verified trial. Professor Ines, the floor is yours.
Thank you very much, Professor Muhammad, a dear friend and colleague also. I'm going to talk about the reimagining diabetes standard of care, the Verify trial. Trial published recently in September 2019. An important trial حقيقة بتطرح مفهوم جديد about reimagining diabetes standard of care. This is the rationale behind reimagining diabetes هنتكلم عليه في الأجندة, and what is the new evidence of early treatment intensification, the Verify trial, and newly published AASD updated consensus report mentioning Verify trial by name. We have either two stepwise approach in diabetes management, to start with a single oral medication, and the patient will disappear for some time and come again uncontrolled, to increase the dose of this oral medication, then to add another oral medication, then to start to add insulin. This is called stepwise approach leading to clinical inertia. Or to start with early combination with combination of oral anti-diabetic medication, and to have stable glycemic control below the target of hemoglobin A1C. عندنا نختار الاثنين, either the stepwise approach or to go through a strict control from the beginning. These are the reasons for early combination therapy. ليه بنفكر في early combination therapy؟ أول حاجة the combination therapy targets multiple pathophysiological defects in diabetes. احنا عارفين ان عندنا 8 او omnius octet 8 target organs and pathophysiological defects in diabetes. When we use a combination therapy, we will target 3 4 2 من pathophysiological defects. Also, we can target the pathogenic abnormality, not just reduce the hemoglobin A1C, and also early treatment intensification prevent or slow the decline of beta cell function. Since type 2 diabetes is a progressive disease and there is early onset of comorbidities, the current treatment with metformin, ان انا ابتدي بمتفورمين واستنى اذا كان هيظبط لي الهيموجلوبين A1C below the required glycemic control ولا لا، وغالبا العيان بيختفي لشهور وبيجي uncontrolled لسه. طيب هل انا اقدر ابتدي بتريتمنت intensification or بايرلي combination therapy؟ ده الحقيقه الكونسبت الجديد اللي بتطرحه الفيريفاي trial. The Verify trial was published in The Lancet in September 2019 to verify the role of initial combination therapy in patients with type 2 diabetes, a double-blind, randomized, multi-center trial, 5-year trial in newly diagnosed type 2 diabetes. بتقارن بين early combination therapy with vildagliptin and metformin versus sequential metformin monotherapy. لما احب اقارن الفيريفايد ترايل هقارنها بترايل شهيره جدا اللي هي يوكي بي جي اس. يوكي بي جي اس in 1998 was studying newly diagnosed diabetic patients. ده يمكن similarity between UKPGS and verified trial ان الاثنين اشتغلوا على newly diagnosed patients. ولما قارن الverify من other very famous trials in diabetes whether type 1 or type 2 هنلاقي ان اغلبهم كانوا بيشتغلوا على patients الهيموجلوبين A1C is higher from 7% to more than 9%. ولكن الفيريفاي ترايل يمكن كانت الترايل الوحيدة اللي اشتغلت على patients with hemoglobin A1C from 6.5 to 7.5%. It was a multinational trial, multicentric trial. 34 countries were included, 254 centers, and 2,001 people with diabetes were included in the beginning. The study design showed the age of 18 to 70 years, body mass index 22 to 40 kilograms per meter square. The hemoglobin A1C, like we said, 6.5 to 7.5%. 50% of the patients were having normal GFR, and 50% were having mild impairment of the renal function. The type 2 diabetes was diagnosed. طبعا البريريكويزيت كان ان البيشنتس دول يبقوا newly diagnosed with maximum 24 months of diabetes, and all were drug naive, and maximum metformin was given for 4 weeks, but no other medication was given to the patients. This is race. Caucasian patients were around 600 in both groups. Other races also were included. And these are the patients' characteristics: females, age, type 2 duration in months, median of around 3 months, and hemoglobin A1C 6.7 in both groups. Body mass index 31 in both groups. The weight also is 85 and 84 kilograms. The GFR were, like we said, 50% had normal kidney, and 50% had a mild impairment of renal function, and the smoking status were also screened. This is the study design. There was a run-in period, 3 weeks run-in period. أول week كان في metformin was given 500 milligram once per day. The second week 500 milligram twice per day. The third week 1,500 milligram were given per day. And those who could tolerate this dose of metformin were included in the study. And there was 2 arms. One arm had early combination therapy of metformin and vildagliptin, and the other arm only metformin with added placebo as an initial monotherapy. Period 1 ما كانش ليها duration محدد، لأن البيشنتس كانوا بيتسابوا في period 1 ويتحلل لهم hemoglobin A1C كل 3 شهور. البيشنتس اللي كانوا الهيموجلوبين A1C above 7 for 2 successive readings كانوا بيعتبروا ان هم initial treatment failure وكانوا بيتحولوا الى period 2. لكن في بعض البيشنتس they didn't fail، ماشيين بنفس التريتمنت بالظبط whether early combination therapy or initial monotherapy. بالنسبة للمجموعة اللي كانت بتاخد metformin plus vildagliptin زي ما قلنا لو كان في 2 successive readings of hemoglobin A1C more than 7% بيعتبروا failed، ولكن بيستنوا على الcombination for 6 months وهنشوف ايه يعني ايه الكونسبت ان هم يتسابوا for 6 months. بالنسبه للمجموعه اللي هي not failed كانوا بيتسابوا على الميتفورمين وفيلداجليبتين اطول وقت ممكن طول ما هم مظبوطين. لما بيحصل treatment failure بيبتدي العيان بيتحول على بيزل انسولين بالاضافه الى الكومباينيشن اوف ميتفورمين اند فيلداجليبتين. بالنسبه للمجموعه الثانيه اللي كانت بتاخد ميتفورمين initial monotherapy لما يكون في 2 successive readings of hemoglobin A1C more than 7%, they move to combination therapy اللي هي metformin and vildagliptin. وطبعا كان في percentage of these patients they didn't fail and they continue on monotherapy of metformin. وده اللي بيبين لنا ليه كان في جروب ابتدت من الاول بالكومباينيشن ثيرابي واتثابت واتقارنت بالمجموعه الثانيه اللي ابتدت الكومباينيشن ثيرابي after failure of metformin. زي ما قلنا كل في period 2 fail to maintain hemoglobin A1C less than 7% for 2 successive readings اتزود عليهم البيزل insulin. What are the main results and safety results? These are the analysis undertaken. Primary analysis was the time to confirmed initial treatment failure. The secondary analysis, the time to second treatment failure, and safety and tolerability of both monotherapy and combination therapy. And there was data about adjudicated cardiovascular events. There are more data coming in the near future. هنستناها. ولما نتكلم على time to confirmed initial treatment failure هنلاقي السؤال: Do those with type 2 diabetes benefit from having combined therapy at the beginning of their pharmacological treatment or not؟ يعني هل البيشنتس اللي انا ببتدي لهم بكومبايند ثيرابي فيلداجليبتين ميتفورمين من بدايه العلاج زي benefit or not؟ وده اللي بان في الريزلتس. early treatment combination strategy significantly reduce the relative risk to time to initial treatment failure by 49% أو 50% versus the initial monotherapy. يعني العيانين اللي كانوا أخدوا early combination treatment كانوا أقل في initial treatment failure 50% من البيشنتس اللي ابتدوا initial monotherapy بالميتفورمين بس. وده المين duration of glycemic control في المجموعة اللي أخدت ميتفورمين كان about 3 years، والمجموعة اللي أخدت ميتفورمين فيلداجليبتين combination from the beginning كانت 5 years، وبعضهم كمان كمل بعد 5 years، وبالتالي your patients have 2 extra years of glycemic control with early combination therapy. ويمكن ده كان main stay of verified trial and the main conclusion of verified trial. لما نيجي نتكلم على second treatment failure نسأل السؤال: Do those with type 2 diabetes benefit more from having combined therapy at the beginning of their pharmacological treatment compared to sequential additive strategy؟ يعني هنقارن المجموعة اللي أخذت combination therapy from day 1 بالمجموعة اللي أخذت combination therapy after failure of metformin monotherapy. ودي كانت results بتقول إن the relative risk for time to second treatment failure during period 2 was significantly reduced by the early treatment combination therapy 26% عن المونوثيرابي. يعني كانوا أقل failure of treatment في second treatment failure بتقريبا 26% في المجموعة اللي أخذت early combination therapy عن المجموعة اللي أخذت early monotherapy of metformin alone. الحقيقه ان كل الريزلتس دي كانت in favor of early combination therapy في كل sub groups، سواء كان المجموعه اللي كانت الهيموجلوبين A1C بتاعها اكتر من 7% او اقل من 7%، المجموعه اللي كانت البي ام اي اكتر من 30 او اقل من 30، الديفرنت ايج جروبس، الجندر، السموكينج ستاتس، كل السب جروب اناليسيس كان in favor with early combination therapy. طب لما نيجي نتكلم على الويت، واحنا عارفين ان الميتفورمين is weight reducing, there was no significant difference in weight between the two groups، المجموعة اللي أخذت initial combination therapy والمجموعة اللي أخذت initial monotherapy. الكلام ده بعد 5 سنين. What about the safety events؟ طبعا أهم حاجة بتهمنا لما أعمل strict blood glucose control هي الهايبوغلايسيميك events، والهايبوغلايسيميك events في early combination therapy كانت 13 event، وفي الانيشال monotherapy كانت 9 event. other side effects زي ما احنا شايفينها serious adverse events and other adverse events all were comparable between the two groups، early combination therapy أو initial monotherapy. بالنسبة لل 9 cases أو 9 events of hypoglycemia and the 13 event of hypoglycemia في المجموعتين they were grade 1 event، يعني no severe hypoglycemia حصلت and mostly were mild events of hypoglycemia. Those who discontinued the medication were low in both groups and comparable، يعني الناس اللي وقفت الدواء سواء كانت وقفت لوحدها أو وقفت due to adverse events كانت قليلة في المجموعتين المونوثيرابي والinitial combination therapy. برضو الادفيرس ايفنتس زي ما احنا شايفين في المجموعتين كانوا تقريبا similar في المجموعه اللي اخذت ميتفورمين مونوثيرابي او فيلدا ميتفورمين. لما نيجي لثالث حاجه تعمل لها اناليسيس اللي هي الادجوكيتد كارديوفاسكولار ايفنت، هنلاقي ان كان في adjudicated cardiovascular events numerically كانوا 30 event in case of early combination therapy compared to 44 event in initial monotherapy with metformin، وبالتالي كانت أقل في المجموعة اللي أخذت early combination therapy، ولكن these results were non-significant. زي ما احنا شايفين الأرقام كانت أقل ولكن كانت non-significant. لما نتكلم على ال summary and the clinical implications هنقول إن ال early combination treatment halved the risk of time to initial treatment failure versus monotherapy, and the median time to failure was 3 years في ال initial monotherapy with metformin compared to 5 years في ال early combination therapy with velda metformin. كمان الفرق بين المجموعة اللي أخذت early combination therapy مع المجموعة اللي أخذت combination therapy after failure of metformin كانوا أفضل 26% في المجموعة اللي أخذت early combination therapy, and both approaches were safe and well tolerated. سواء كان mono therapy أو early combination therapy الاثنين كانوا safe and well tolerated. And the conclusion of Verify, the strategy of an early combination treatment approach with vildagliptin plus metformin in patients with newly diagnosed type 2 diabetes significantly and consistently improves long-term glycemic durability compared with metformin monotherapy. طيب هل الكلام ده اتقال في الجايد لاينز؟ بالفعل اتقال في الجايد لاينز او الكونسنسس الاي جي اي والاي اس دي 2019 قالت ان في little evidence about the approach of early combination therapy، ويمكن دي كانت hint بس على الفيريفاي ترايل، ولكن بعد كده في الدايابيتس كير اتنشرت 2019 update طبعا الكونسنسس اللي كلنا عارفينها. قالت ايه؟ قالت ان في there is limited evidence for initial combination therapy وقالت ان الفيلداجليبتين efficacy in combination with metformin for early treatment of type 2 diabetes اللي هي ال verified trial proved additional information. طلعت نتائج اكتر من اللي كان بيتقال عليها little evidence في الكونسنسس اللي قبلها. The initial combination lowers the rate of secondary failure of glycemic control. الهيموجلوبين A1C طبعا اللي هو اقل من 7 versus metformin alone or the sequential addition of metformin and vildagliptin. يعني اتكلمت على ال verified trial وقالت ان كان في lower rate of primary treatment failure و secondary treatment failure كمان, and these results have not been generalized to other orals than vildagliptin. يعني it's not a class effect, it's not a group effect, it's not an effect of oral anti-diabetic medications, ولكن these results were particular to vildagliptin. واتقال ان احنا initial combination therapy is a new concept in cases of type 2 diabetes, ولكن you have to consult your patient وتفهمه انا ليه بدي combination therapy from the beginning. بشكر حضراتكم، شكرا لكم.
دكتورة إيناس، المحاضرة كالعادة أكتر من ممتازة، وإحنا كلنا كالعادة بنستمتع بمحاضرات حضرتك، وأنا بشكر جدا يعني the lady of diabetes في مصر الدكتورة إيناس شلتوت، the professor of internal medicine and diabetes, faculty of medicine, Cairo University, the president of the Arabic Association for the Study of Diabetes and Metabolism. And we just, have to start the discussion. We have a question now about the monotherapy versus combined therapy. Is it, is it, it's better, or what's your recommendation about this? Is this one of the questions we received from the floor, Dr. Ines?
طيب أنا الحقيقة إحنا عندنا من 2012 عندنا في الجايد لاينز كونسبت اللي هو individualization of treatment. يعني مش كل العيانين كمان أنا ببقى حابة إن التارجت بتاعهم يبقى less than 7%. أنا عندي جروب أوف بيشنت ببقى محتاجة إن الهيموجلوبين A1C تارجت بتاعي يبقى أقل من 6.5 ويبقى عندي strict diabetes control. البيشنتس دول هم newly diagnosed patients، يعني الكلام ده يمكن قبل حتى الفيريفاي، قلنا الكلام ده من 2012. newly diagnosed patients، patients with no risk for hypoglycemia, no repeated hypoglycemia, no hypoglycemia unawareness، patients without comorbidity على الليفر او الكدني او الهارت، patients طبعا ما يكونوش geriatric patients. patients دول لو أنا استخدمت لهم treatment which is not causing severe hypoglycemia، كنا بنحب إن الهيموجلوبين A1C تارجت بتاعهم يبقى أقل من 6.5، وإن أنا أبقى حتى من 6 ل 6.5. فده قلناه من 2012، ويمكن هو ده نفس الكونسبت دلوقتي. وإحنا خلينا نأكد تاني إن إحنا كل وقت بيقضيه عيان الدايابيتس with strict control of his blood glucose، ان ده بيقلل من complications on the long run. وطبعا حضرتك هتقولي لنا على cardiovascular disease، بيقلل لي complications whether macrovascular complications or microvascular complications. يبقى انا لو اقدر اعمل العيان بتاعي strict blood glucose control، وده يمكن زي ما قلنا من بدايه 2012 وهو في 2019 بيتاكد لنا ببعض الترايلز، واللي احنا طلبناه من نوفارتس ان هي to update us with يمكن هيطلعوا داتا بتهيألي على المايكروفاسكولار complications. كانت المفروض ان هي هتطلع في كوارتر 2 من السنه. طبعا يمكن مشاكل اللي بيمر بيها العالم هتأجل شويه النتائج، ولكن احنا منتظرين نشوف الإفكت of this early tight glycemic control على الcomplications.
This is amazing. I have two other questions, Dr. Ines. The next what are the ranges of initial glucose measurements allowing the use of this early combination, metformin and vildagliptin?
هو احنا مش هنتكلم على بلاد جلوكوز قوي، احنا بنتكلم على هيموجلوبين A1C. يعني البلاد جلوكوز متغير يوم بيوم، ولكن احنا بنتكلم على هيموجلوبين A1C. ويمكن هنا الفيريفايد ترايل اتكلمت على الجروب اللي هي الهيموجلوبين A1C بتاعها من 6.5 ل 7.5. عندنا طبعا لو احنا هنرجع للجايد لاينز كلها بتتكلم على 7% هيموجلوبين A1C، ان انا ببتدي بمونوثيرابي ميتفورمين، وان انا بستنى 3 شهور واشوفه لو ما كانش العيان هيوصل لي اقل من 7%، المفروض ان انا to add on another oral anti-diabetic medication. ولكن هنقول ان احنا عندنا نفس الجايد لاينز من زمان بتقول لنا ان انا اقدر to go to a more strict hemoglobin A1C reduction لما اقدر ولما العيان يبقى safe ان انا to give him treatment هنقول with no risk of hypoglycemia، ويكون العيان ما عندوش comorbidity ممكن تعمل لي مشاكل. ف it is a new concept. وبعدين احنا مش احنا اللي بنقول الكلام ده، ده نزل في الجايد لاينز من 2018 و2019 و2020.
The last question, Dr. Ines, what about the initial treatment with other combinations?
احنا ما عندناش ترايلز، يعني حتى الاي جي اي قالت ان ما تقدرش تعمم هذا الكلام على الاذر ميديكيشن، سواء كانت other medications of the same group or other oral anti-diabetic medications. وقالت ان الكلام ده اتعمل في الفيريفايد ترايل على الفيلداجليبتين ميتفورمين، وبالتالي احنا مستنيين اذا كان في ترايلز اتعملت على الاذر groups of anti-diabetic medications او الاذر classes of GPP4 inhibitors.
Thank you very much, Professor Ines Shaltut, the Professor of Internal Medicine and Diabetes, the Faculty of Medicine, Cairo University, the President of the Arabic Association for the Study of Diabetes and Metabolism. Now I have the honor to introduce our next speaker, and actually he's one of the world figures in endocrinology and diabetes, and we are proud always of him. This is Professor Muhammad Hassanein of endocrinology from England. And we're very happy to have Professor Muhammad Hassanein, the Associate Director for Postgraduate Diabetes Education at Cardiff University, the United Kingdom, the Chair of Diabetes and the Ramadan International Alliance. Yes, the floor is yours, Professor Muhammad Hassanein.
Thank you very much, Professor Gamila, for your kind introduction. Thanks for Professor Ines for the invitation, and for our sponsors, Novartis, for extending the invitation to me as well. So I would like to follow with what Professor Ines have mentioned on the clinical trial, and look into 3 short cases on how can we apply these recommendations and the guidelines, as well as the new clinical trials on everyday practice. Whether it's applicable or not, that is what we will see together now. So let's just proceed with the first case scenario. So there are very simple case scenarios. There is nothing difficult or complex in them. These are typically patients that you see every day in your clinical practice. So my first case is a teacher of 55 years of age. He's a male. He has history of hypertension and ischemic heart disease for the last 2 years, ischemic heart disease, hypertension for longer. His EGFR is a bit reduced to 65. His HbA1c is 8%. His body mass index is 28. He's currently on dual therapy of metformin and gliclazide, as well as treatment for the hypertension, the ischemic heart disease, and a statin. And let's focus on the glycemic control. Let's not get into other issues. So from a glycemic control point of view, what should we do? So I show you here the algorithm of the AASD, which was published initially in 2018 and got recently updated. And as you can see here, in 2018, they are talking about people with established atherosclerotic cardiovascular disease or chronic kidney disease. If this is the case, then regardless of the HbA1c, we need to consider adding either a GLP-1 receptor agonist with proven benefit or an SGLT2 inhibitor with proven benefit. Which one do you choose? The consensus, if it's more of heart failure or kidney problems, then it's an SGLT2. If it's more of an atherosclerotic problem, then it's a GLP-1. When they updated the recommendations earlier this year, January of this year, they looked into not just the established atherosclerotic cardiovascular disease, but those with very high risk, which in my mind, this is actually disease, because as you can see here, they're talking about people with left ventricular hypertrophy, with coronary or carotid or lower extremity artery stenosis of more than 50%. So there is already an angiogram that has been done either on the coronaries or the lower extremities or some sort of a Doppler that established that there is 50% or more of stenosis. Anyhow, that was the ADA and the ESD recent recommendation and recent update for the recommendations. I personally have the pleasure of being part of the very recently published Emirates Diabetes Society recommendations for the management of type 2 diabetes. And here we have looked into risk categorization. We've looked into the various guidelines that is available, and we've modified them to the local requirements. So someone like our patients that we've just talked about, a 55 years old male with established ischemic heart disease, what we said here is either this or a target organ damage, then they are considered as very high risk. If they don't have an organ damage, but they have diabetes for over 10 years and they are aged over 50 years and they have more than two or more risk factors, they are considered also as very high risk. So that would apply to our case, and the recommendation is to start either a GLP-1 or an SGLT2 with benefit regardless of the HbA1c. So this is an important point. So the HbA1c here is not a factor in the case that I've presented. And then if they fail, we can intensify the treatment, as you all know. But I think we have focused massively on cardiovascular outcome trials, and I think we have to put everything into context. When you look into the cohort of patients of the EMPA-REG or the Canvas program or the DECLARE study, how many of them apply to everyday patients? For EMPA-REG, it's 92% who would not be eligible for EMPA-REG, for empagliflozin treatment. In the Canvas program, it was 80% would not be eligible from the cohort published in the BMJ earlier last year. DECLARE, because it included many people with multiple risk factors, it was considered to be 60% would not be eligible for this. So while a lot of the scientific discussion is talking about the cardiovascular and the renal patients, let's not forget that's not the majority of our patients, at least in the early stages. If you apply the same to the NHANES data of 240 million persons with diabetes in the States, you will look into the cohort of patients that's been taking part into these excellent GLP-1 receptor agonist cardiovascular outcome trials, you will find that they would range from as low as 8% to as high as 22%. So clearly, the vast majority of our patients are not necessarily patients with existing cardiovascular disease or extremely high risk that would necessitate this automatic addition of an SGL2 or a GLP-1 receptor agonist. I looked into a study that we've published, Professor Ines is a co-author in the Dia-Ramadan study, which is on gliclazide MR. And I just want to highlight that of the baseline characteristics of our patients with a mean age of 54, with a mean duration of diabetes of 5.4 years, there was only 6.3% with established cardiovascular disease. There was about 28 to 35% with either dyslipidemia or arterial hypertension. So risk factors are there, but established cardiovascular disease is not necessarily the majority of our patients, and this is something that we need to remember and we put into context. So let me go to the second case, which is more of what we see frequently in our practice. This is a person who's 45 years of age, male, hypertensive, with a BMI of 29, with a normal renal function, and this person is already on a reasonable dose of metformin of 1500 milligrams. Of course, he's also on the other treatment for his other conditions, such as the antihypertensive and the lipid lowering, considering that the person has hypertension. So when I think of this person risks, I see that his diabetes duration is only 4 years, he's under 50 years of age, he has 2 added risk factors. So when I apply our scheme that we've produced from the Emirates Diabetes Society, that here is the patient under 50 years, under 10 years of diabetes duration, with 2 risk factors, 2 added risk factors that put this person on a moderate risk. He will still be on a moderate risk if his diabetes duration to increase or if his age to increase, but with less risk factors. So this is important to remember. And this is typically the type of patient that you would like to say, okay, I'm already on metformin. What should I use of these classes of drugs? They're all available to me. How do I choose? Well, you need to think of the efficacy of the drug you want to choose, the risk of hypoglycemia, the impact on weight, the cost, and of course, the baseline HbA1c. Because if the baseline HbA1c is above 10, then the recommendation is to go to insulin, according to the guidelines. Otherwise, you can think of any of these equally according to the individual case. And all of these parameters, including, of course, cost, is one of the important parameters. Of course, you would intensify the treatment, but you would avoid having 2 incretin-based therapies together. And then eventually, if the person is not well controlled on triple therapy, then you would intensify the injection or initiate an injection. So clearly, the ADA and AASD are not disputing what we should do, but they are just highlighting, as what Professor Ines in her presentation mentioned. She has mentioned the word 3 months, and this is what we all unfortunately ignore. We don't wait for 3 months, we wait for 3 years to add the second line drug from monotherapy to dual oral therapy. And if they're on dual oral therapy, we wait for 7 years to add the third line. And then eventually to add insulin, we even stay for a similar time on a person already on triple therapy. So that is something that's been highlighted in the studies that have been published over the last 6-7 years, and we really need to stop this inertia, specifically when we know in some sectors of therapy that our patients might not be available to see frequently in our clinic. You've seen this slide by Professor Ines. I'm not going to repeat it again. All I'm saying is this is what we want to do. We want, from very early in the therapy, use whatever weapons you have, lifestyle, education, and the right combination therapy to get your patient in control and remain in control for as long as possible without this yo-yo situation, which is not really helpful. Why is that? Because it does matter. It does matter. When you look into the difference between this person, whose HbA1c was in the mid-8s, going down to roughly about 7.5, which many of us would say, it's so good, it's okay, I don't need to have intensive treatment. Well, when you have this sort of okay, this is what you end up with. After 5 years, as been shown in this published by Kunti et al., published 3 years ago, that you talking about higher rates of myocardial infarction, higher rates of stroke, higher rates of heart failure, and higher rates of the composite cardiovascular events. So it does matter, and we should not really have this sort of attitude of it's okay. No, we need to get good control for our patients. Because what we've seen from the VERIFY trial is that the lines separate quickly. What are these lines? This is patients with events. What we're talking here about is macrovascular events. Yes, the hazard ratio was crossing the line. Yes, the p-value was not significant, but I don't think that anybody would be happy with higher numbers of cardiovascular events in their cohort of patients. So really, this is important for us to remember. So I would like to move to my last case, which would apply very much to the discussion that you just had with the verified case, because this is a new diagnosis. This is a 39-year female with type 2 diabetes. She has no history of other comorbidities. Her HbA1c is 8%, BMI is 28, non-smoker, LDL is 110 with a total cholesterol of 165. How should we treat? Well, there is no doubt that metformin needs to be part of that. But as Dr. Ines mentioned, here is the update of the ADA for 2020, where they published their points. And here they're saying the initial combination of the DP4 inhibitor vildagliptin with metformin was shown to provide a lower rate of secondary failure of glycemic control to HbA1c above 53, which is 7, versus metformin alone, or the sequential addition of metformin plus vildagliptin. So it's not just about the molecules, it's about the timing of the molecule. That is really what is quite important. It's quite important for us to remember that it's not just the vilda or metformin or another drug. It is the molecule and the timing of the molecule. That is really quite important for all of us to remember. So that's why they are saying is that we suggest have that discussion. They were not strong enough to say, we recommend changing the guidelines. They did not say that, but they stopped short from saying this by saying, consider it, think about it, discuss it with your patient, because after all, you can gain longer duration of good control. The added years with good control can give the person the confidence. And of course, I agree with Professor Ines, we need to see the impact of this on microvascular complications. Macrovascular complications, we know it might need longer time, but with the microvascular complications, it could be much shorter. But for the treatment here, the number of events, it is not really about whether the person got the second drug or not. It's about the timing. Initially, you combine or you add on when required. And that's the difference between the early combination and the initial monotherapy that required the addition of the drug a bit later. So you see here, there was no failure in 5 years, 60 months, there was no failure on the early combination, while obviously in the other groups, there was a need to intensify and to add therapy as you go. And we've seen this in ADOPT trial. We've seen this before, many years back in 2006 in ADOPT trial, that when you use monotherapy, you will have good control for a number of years, but then gradually, whether this is a glitazone or a metformin or a sulfonylurea, gradually the control will need to be intensified again. So it's a matter of why can't we do something to remain here rather than we end up here and then start to try to get it down again, and whether this is successful or not. So if I were to go back to this case of the early diagnosis, this is a person under the age of 50, newly diagnosed with one added risk factor. This person is a low risk. So what we use for low risk or for moderate risk or even for high risk is any of these. You choose what you think, and what Verify is saying to us, it's not just about the class. I mean, for cardiovascular outcome trial, we say the drug with evidence. We always keep saying the word drug with evidence. So I might as well use this if we are to use the early combination. As per the previous question to Professor Ines, is which one would you use? I would say the one I have is the one with evidence. So all the time, we have to balance things. We have to balance things between the timely and the effective and the stable glycemic control to improve glycemia and prevent complications versus the risk that the drug can have, such as hypoglycemia or weight gain, or maybe it's the impact on other factors as well. So this is really what you need to think of. And I really like the fact that our patients often with the combination therapy don't feel it's two drugs, because the availability of the combination in a single tablet is there. The psychology, and we've heard Frank talking about the psychology for our patients. Certainly we know that the psychology of multiple drugs make people not so happy, but when they see that they are on single tablets, it may improve adherence. And adherence is obviously linked to the HbA1c, which we all are keen on. So my take-home message is really quite simple. Cardiovascular and renal risk quantification is essential for all our patients. And this is important to do and important to follow, and we have good evidence. But this is not the majority of my patients. We need to provide a treatment that is tailored according to the patient profile. The profile could be the comorbidities, could be the risk of hypo, could be the weight, and could be the finances of the individual, as well as many other factors. When we are thinking of all of these points, it's really important to apply evidence-based medicine. The choice of therapy needs to be backed up with evidence. We are sometimes blamed for the physician inertia, and we need to try to overcome this, because this inertia could lead to avoidable morbidity and mortality. Our patient with diabetes, they already have a risk that we want to reduce, and we don't want to increase that risk by our own inertia. Early intensification is an important concept as mentioned by the ADA, that we should consider for many of our patients and discuss with them and see whether this would be the right choice for them or not. After all, the ideal treatment for diabetes, you need to think of all of these parameters. Efficacy should be high. Weight should be either neutral or indeed to help losing weight. Risk of hypo need to be abolished or low. It needs to obviously to address the problems of diabetes, including fasting and postprandial hyperglycemia, need to be simple to administer with a very low profile of side effects, with evidence and with cost effectiveness. I would love that someone would tell me which drug is this. I'm sure you will all try to think if it does exist or not. Thank you all, and I look forward to any questions that you have now. Thank you.
elegant 2 طبعا هي بتكمل المفهوم بتاع. عايزة أسأل حضرتك هل أنتوا بتستخدموها فعلا في العلاج ولا أنتوا يعني stick to the guidelines؟ لأن طبعا لسه الجايدلاينز ما قالتش كلام واضح على ال early combination therapy.
أنا معاك يا دكتورة إيناس إن the guidelines did not strongly put that forward that it must be done, but it's certainly a point of consideration. Some colleagues love early combination, love to address the aggressive intensification from the beginning, and some are waiting to see whether the patient gets out of control to add another drug. So, I mean, maybe in my hospital, because we are a referral center, we normally see the complex patients that need multiple therapy or injections, or they have complications. I don't necessarily see many of the initial diagnosis. This is usually done in primary care. And another point which is a bit different than the practice in Egypt, where it's mostly reliant on the person himself booking an appointment, they need to come to us anyhow to get their medication. And we see them usually within 3 months. The maximum is 6 months, because we cannot prescribe longer than 6 months. So we are not concerned about the patient disappearing. In fact, it's the opposite. The patient wants to come more frequent. We don't have the slots for the appointments to see them that frequent. And that was the same in UK, where it's an NHS, an insurance-based system, where the patient need to come to the doctor to get their medication anyhow. So I'm not concerned about losing the patients. But the concept is tempting. I have to admit that the robustness of the study is nice, is good. It would be lovely to see, obviously, some similar studies as well to move in that direction.
في سؤال طبعا هو يمكن مش يعني جاي لحضرتك. What is the most safe treatment for diabetes with pregnancy? Is basal insulin safe during pregnancy or not?
I don't mind taking it. I do the antenatal clinic for the last 20 years. In pregnancy, there is only 2 classes of drugs, insulin and metformin. Sulfonylurea glabenclamide is approved, but because we know it has a high rate of hypoglycemia, we very rarely use it. So for type 2 diabetes or for gestational diabetes, we tend to use metformin initially. And if the person gets out of control, we add on insulin. Which insulin depends on the profile of the person. If it's hyperglycemia all day, then we use both basal and prandial. If it's only fasting hyperglycemia, we use the basal insulin.
في سؤال يعني هو يمكن يبقى معانا احنا الاثنين نقول الإجابة. I think before combination therapy in diabetes type 2, behavior therapy and lifestyle medication should be at start. What's your opinion? يعني هو lifestyle موجود from day 1 to the end. يعني lifestyle ما وقفش ومالوش علاقة بالميديكيشن، هو لازم يبقى موجود. ايه رأي حضرتك دكتور محمد؟
بالتأكيد، ويمكن دي كانت السلايد تشينج من الاولدر فيرجنز اوف ذا جايد لاينز اللي كانت بتقول استنى 6 شهور على لايف ستايل، لكن الكرنت سيتويشن بتقول don't wait and but the lifestyle is continuous. It's very important that we address the behavior of the person, because if they don't address their behavior, they will need not just monotherapy or dual therapy, they will need intensive therapy with insulin within a short number of years.
Thank you, Professor Muhammad, for the sake of time. واحنا مسهرينك وعارفين ان انت عندك الوقت متأخر قوي في الامارات، وخليني let me introduce my dear colleague Professor Muhammad Nasrallah. Professor Mohammed Nasrallah is a professor of nephrology, Cairo University. Professor Nasrallah هيتكلم على management of diabetes with CKD and which medications are safe for CKD diabetic patients. الحقيقة موضوع مهم. دكتور محمد اتفضل.
بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على رسول الله. أنا هبتدي بقصة صغيرة كده كانت حصلت لي من حوالي 4 أو 5 سنين. كنا في ميتنج كده ظريف، وكان من الميتنجز اللي كان فيها diabetologists ونفرولوجيستس، وبعدين طلع كده سؤال على الميتفورمين، وهل دكاترة الكلى يعني هل نستخدمه في عيانين الكلى ولا لا؟ معلش انا مش عارف الصورة واصلة ولا لا، لان انا عندي طيب. فالحقيقة انا ساعتها الجايد لاينز ساعتها كانت بتقول انه عيانين الكلى ما ياخدوش ميتفورمين خالص الا لو الكرياتينين بتاعهم مش فاكر ازيد من 1.5 ولا 1.3 رقم كده، ما اعرفش جابوه منين. وكانت احنا كنفرولوجيست عندنا بلethora من الداتا يعني كتيره جدا جدا from so many observational studies. احنا it's very safe to use metformin. lots of experience lots of data. ولما قلت الكلام ده قام احد الساده الافاضل الدايبيتولوجيست زعل مني جدا جدا جدا، وقال لي انك انت اللي بتعمله ده ما يصحش ابدا وعيب عليك، وكان عايز يوم يضربني يعني، ولا ايه انا لازم اضرب الراجل ده باللفظ فعلا يعني قبل ما يموت العيانين. ليه؟ علشان عايز يستخدم ميتفورمين في عيانين الكلى. حاولت اتناقش معاه بالعلم، ولكن هو كان مخه فيري ستيف قوي في حته الجايد لاينز. الجايد لاينز مهمه، لكن اللي انا عايز اقوله ان ساعات الايفيدنس بيبقى موجود والجايد لاينز تبقى بطيئه شويه على ما تتبناه. انا مش عارف بيور سبوت مش لو يسيبوا لي بس حريه اكتر في الحركه. طيب اوكي. فالحقيقه انه احنا عارفين ان about 40% من عيانين التايب 2 diabetes هيجي لهم كدني ديزيز، والمورتاليتي في الناس دي is about 35% على مدار ال10 سنين اللي بعد ما يجي لهم الدايابيتيك نفروباثي. والمورتاليتي دي بتقل حوالي 30% لو العيانين دول كانوا ماشيين على ميتفورمين. عشان كده الميتفورمين احنا بنعتبره من الادويه اللي ما عليهاش خلاف. وقعدت افكر، هذا الدكتور اللي كان زعلان مني جدا علشان انا عايز اكتب ميتفورمين لعيانين عندهم كرونيك كيدني ديزيز، لو هو راجل فعلا دايبيتولوجيست بيشوف عيانين كتير، المفروض انه يكون بيشوف على الاقل 500 عيان مثلا جديد في السنه، متوقع 200 منهم يجي له دايابيتيك نفروباثي او يكون عنده دايابيتيك نفروباثي. يبقى المورتاليتي ريت بتاعتهم بحسبه سريعه كده متوقع تبقى اراوند 70 هيموتوا من ال 200 دول في خلال 10 سنين، يعني في السنه هيتوفى 7، كان ممكن يبقوا 5 بس لو كنا هدينا وفكرنا وبصينا على الايفيدنس اللي موجود. ف one of the main things I'm going to be defending today is the use of metformin في عيانين الكلى. والحقيقه علشان نوصل لهدنه وتفاهمات ونقدر manage the patients, let's ask ourselves 12 سؤال, a dozen of questions, يعني 12 سؤال هنسالهم النهارده من الاسئله المشتركه اللي بنشوفها كتير بين دكاتره الكلى والسكر، ونحاول نوصل لاجابات يكون فيها consensus ونتفق فيها مع بعض. انا مش هبقى بتكلم على المانجمنت اوف دايابيتس طبعا لان ده موضوع ما يخلصش يعني، ده علم يعني، ولكن خلينا نتكلم بس على الهايبرجلايسيميا بس بسرعه. المانجمنت اوف جلايسيميا العيانين اللي عندهم كرونيك كيدني ديزيز. هل هو في فرق بين عيان الكرونيك كيدني ديزيز الدايابيتيك وعيان الدايابيتيك اللي ما عندوش كرونيك كيدني ديزيز؟ من الناحيه النظريه طبعا في فروق كتيره جدا. الميتابوليزم بتاع كل حاجه ريليتد للدايابيتس بيتغير بمجرد ما العيان يبقى عنده كيدني ديزيز، من اول انسولين ريزيستنس بالعكس الديكريزد انسولين كليرنس والجلوكونيوجينيسيس اللي بيتاثر، الجي اي تي موتيليتي، الابيتايت، فوميتنج والجاستريك امتينج، والحاجات دي كلها ممكن تؤدي الى هايبوغلايسيميا او فلكتويشنز في الليفل بتاع البلاد شوجر والابزوربشن بتاع الدراجز اتسترا. وطبعا الدراج ميتابوليزم كله بيتغير. الحقيقه احنا دايما بنفوكس على الميتابوليزم بتاع الدراجز، بس هو الحقيقه لا، الكرونيك كيدني ديزيز بيأثر على almost every single aspect that we can imagine في الباثوفيسيولوجي بتاع الدايابيتس والفارماكولوجي بتاعت الدراجز اللي بنستخدمها. طبعا زي ما قلنا الهايبوغلايسيميا، العيانين دول are very prone to hypoglycemia، ودي من الهول ماركس اللي دايما بتخلينا نفكر هستخدم ايه؟ ما هو العيان في الاخر لازم هظبط سكره. ساعات نبقى عايزين نبعد عن دواء معين علشان زعلان منه زي مثلا الميتفورمين، فاستخدم ادويه ثانيه تعمل more hypoglycemia which is even much more serious as I will show you in a minute. السؤال الثاني وده شفته على فكره بعض الناس سالوه في الشات، سؤال هو ايه الجلايسيميك تارجتس بتاعت عيانين الكلى اللي عندهم سكر؟ زي ما دكتوره ايناس كانت بتقول من شويه، هو الموضوع مش موضوع بقى جلوكوز وهنقيس السكر الفاستنج والبوست برانديال، تاني خلاص بطلنا نعمل كده، لكن بقينا بنبص على other measures اللي منها الجلايكيتد هيموجلوبين. عيب الجلايكيتد هيموجلوبين في عيانين الكلى انه بيتاثر وبيتغير بحاجات كتيره قوي related للالترد اريثروبويسيس في العيانين دول. فعيان الكلى لو خد اريثروبوتين او حديد او بي 12 الجلايكيتد هيموجلوبين هيبقى فولسلي لو، يبقى شكله حلو وهو سكره مش متظبط، والعكس. طبعا blood transfusion بيأثر، ونفس البريزنس اوف يوريا in the blood alters الليفل بتاع الجلايكيتد هيموجلوبين والبي اتش and so on. وبالتالي it becomes rather inaccurate throughout history. بقى حاول الناس ان هم يدوروا طيب على حاجه احسن. اعتقد دكاتره السكر ما بيسالوش السؤال ده، لان السؤال ده بنتساله كتير من دكاتره الكلى، الفركتوزامين والجلوكوزامين، وبقول لهم الكلام ده يا جماعه مش عايزين دكاتره السكر يسمعونا واحنا بنتكلم عليه علشان ما يضحكوش علينا، لان هذا الكلام يعني قدم قوي وبقى عامل زي اللي بيتكلم على انسان الكهف يعني. these measures, even though they could have been useful if they were studied properly on time, but they were not studied properly in terms of اني اوصل لاني اعرف انهي ليفل انهي تارجت الايفكت بتاع الادجستمنت بتاعت الحاجات دي على الاوتكمز، الافيلابيلتي بتاعتها اتسترا اتسترا، دول مش هنتكلم عليهم. لكن الحقيقه اللي بيحصل دلوقتي انتوا حضراتكم عارفين بنستخدم السيلف مونيتورنج اوف بلاد جلوكوز، وده قد يكون افضل في عيانين الكلى كمان، علشان زي ما قلنا الجلايكيتد هيموجلوبين ما يبقاش ليه عيوبه، وربما الكونتينيوس جلوكوز مونيتورنج. طيب ايه التارجتس؟ ودي من الاسئله برضو اللي شفتها على الشات من شويه، كانت بعض الافاضل الحاضرين بيسالوها، والحقيقه الاجابه قالتها ضمنيا دكتوره ايناس وقالها ضمنيا الدكتور محمد حسنية قبلي، ان هو you have to look at your patient as a whole. هو عنده سكر بقاله قد ايه؟ هو ايه الريسك بتاع المايكروفاسكولار ديزيز اللي عنده؟ ايه الريسك بتاع الماكروفاسكولار او الكارديوفاسكولار ديزيز اللي عنده؟ ووزنه و عيان الكرونيك كيدني ديزيز البروفايل بتاعه كالاتي، غالبا ما بقولش دايما ولكن غالبا عيان التايب 2 دايابيتس ابو دايابيتيك نيفروباثي ده عيان عنده سكر بقاله شويه كتير. طبعا احيانا بيبقى العيان عنده كرونيك كيدني ديزيز من اول ويجد عليه سكر ويبقى السكر لسه جاي، دي قصه ثانيه، لكن غالبا الاثنين لما بيجوا مع بعض بيبقى السكر في اغلب العيانين اكتر شويه. فده عيان ما قالوا عنده سكر بقاله شويه وعنده هاي ريسك اوف هايبوغلايسيميا وعنده هاي ريسك اوف ماكرو فاسكولار ديزيز. عيانين الكلى بنعتبرهم فيري هاي ريسك كارديوفاسكولار ديزيز بيشنتس، وباي ديفينيشن هو اغلبهم بيبقى عنده اوريدي مايكرو فاسكولار ديزيز. فده عيان هاي ريسك، مش بس هاي ريسك، ده عيان كمان جات له الموربيديتيز اوريدي. طيب تعالى نعمل لهم بقى انتنسيف جلوكوز لورنج علشان نقدر نقلل الريت اوف بروجريشن بتاع الكدني ديزيز، لان احنا عارفين انه بيزيد مع الوقت. العيان بيبتدي معانا بشويه هايبر فلتريشن وبعدين يبقى عنده جريد 1 البومينوريا اللي هي بنسميها مايكرو، وبعدين ماكرو البومينوريا and so on. طيب تعالى نمنع البروجريشن ان احنا نعمل intensive glucose lowering. We all know from most of the studies ان when you do this الحقيقه ممكن فعلا تقدر تقلل قوي المايكرو فاسكولار ايفنتس، وممكن فعلا we have evidence ان this will lower the progression of kidney disease. حاجه حلوه قوي، ولكن الحقيقه ولا المورتاليتي ولا الكارديوفاسكولار ديزيز غالبا بيتاثروا قوي. ربما يكون ده بسبب الهايبوغلايسيميا اللي بتحصل، الديفنسيف ايتنج والويت جين والكارديوفاسكولار كومبليكيشنز والاريثمياز اللي بتيجي مع الهايبوغلايسيميا اتسترا. ولكن هايبوغلايسيميا كانت دايما بتبقى عقبه في ان احنا نوصل لبروبر اوتكمز في العيانين بتوع الكلى وعيانين السكر ان جنرال الحقيقه. طيب التارجت في الاخر ايه؟ في عيان الداياليسيس it is around 6.5 to 8.5. اكتر من كده واقل من كده المورتاليتي بتزيد. خلي بالنا عيان الداياليسيس غالبا عيان very high risk of cardiovascular disease، وغالبا already عنده cardiovascular disease يعني pre-existent يعني. ف we should be careful و they are very prone to hypoglycemia و hypoglycemia unawareness. So we should be a little bit careful. وطبعا زي ما قلنا جلايكيتد هيموجلوبين بيتاثر بالليفل بتاع الهيموجلوبين والبلاد ترانسفيوجن والاريثروبوتين والحديد والحاجات اللي احنا بنديها للعيانين. ولكن خلينا نقول انه most of the studies that we have show that the least mortality is in the range of around 6.5 to 8.5. Most of us would keep those patients around 7.5 to 8, 8.5 لو اكبر في السن شويه، ان كتير منهم بيبقوا عيانين كبار وفريد. طب في النون داياليسيس population حاجه تكسف الحقيقه، we don't have good studies that were specifically performed on non-dialysis chronic kidney disease patients. اغلبها بتبقى observational studies او حتى interventional studies اتعملت على الجنرال diabetic population وطلع فيهم كام واحد chronic kidney disease واتعمل عليهم post hoc analysis. ما نقدرش ناخد منه داتا قويه جدا، ولكن we extrapolate الداتا بتاعت النون diabetic patients، بتاعت diabetic non kidney disease patients. اللي هو كل ما العيان يبقى اصغر في السن ولس برون لهايبوغلايسيميا ولس cardiovascular disease ومور ريسنتلي diagnosed diabetes، كل ما تبقى ميال ناحيه انك تيجي ناحيه الجلايكيتد هيموجلوبين يبقى قرب ال6.5 وال7 علشان تمنع البروجريشن بتاع المايكروفاسكولار ديزيز. وكل ما العيان يبقى اكبر ومور فريل وعنده كارديوفاسكولار ديزيز وهايبوغلايسيميا برون، كل ما بتزقه ناحيه الجلايكيتد هيموجلوبين يبقى اعلى ناحيه 7.5 و8 and so on. طيب هل الجلايسيميا تارجتس دي هتاثر طيب على البروجريشن اوف كيدني ديزيز؟ اكيد. يعني I know that the evidence looks heterogeneous من الشكل بتاع الفيجر اللي قدام حضراتكم، ولكن ده تاني لانه those studies were mostly not studies that specifically looked at kidney disease as an outcome يعني. طيب نيجي للسؤال اللي بعد كده، السلفونايل يورياز. احنا زي ما اتفقنا هجاوب على 12 سؤال، كتير قوي لما بقعد مع اصدقائي وزملائي واساتذتنا من دكاتره السكر بتثار هذه الاسئله. هل السلفونايل يورياز ينفع نستخدمها؟ يعني لا بحبك ولا بقدر على بعدك. يعني ايه ما بنحبهمش؟ محدش بقى يحبهم قوي علشان الهايبوغلايسيميا، بس هي ادويه فيري افكتيف الحقيقه. they are very effective drugs، ينزلوا السكر قوي ورخاص جدا ومش نيفروتوكسيك. والهايبوغلايسيميا هي مشكلتنا الاساسيه فيهم، خصوصا مع اللونج اكتنج دراجز. فهايبوغلايسيميا هي المشكله الاساسيه، وخصوصا العيانين دول بيجي لهم هايبوغلايسيميا وبيبقى ممكن مع الدراج يبقى ريتيند، تبص تلاقي اديته جلوكوز فاق ورجع جاله هايبوغلايسيميا تاني ويروح العيان يجي له another hypoglycemia at home that sometimes can be fatal. طيب دي حاجه I need to address just a few drugs specifically، لاني بلاقي انه في بعض المازال موجود عندنا حاجات عايزه بس تبقى ابديتد، اللي هو الكونسبت القديم بتاع انه الاماريل هو الافضل لعيان الكلى. الاجابه ان ده مش صح. الاماريل ليس الدواء، الجلايمابرايد عموما is not the best drug, it's not the best sulfonylurea for patients with chronic kidney disease in terms of انه اقل عرض بيعمل هايبوغلايسيميا اقل. الكلام ده مش صح. الكلام ده طلع الحقيقه from some very old American studies، لان هم ما عندهمش جلايكلازايد في امريكا. فلما قارنوا الجلايميبرايد قارنوه بالدواء الجلايبنكلاميد اللي مشاكله كتيره قوي في الهايبوجلايسيميا، فقال لك ده احسن. الحقيقه انه if you are going to choose a sulfonylurea مضطرا واسفا، وده بيحصل كتير في عيان كلى، glyclazide is the answer. It's not glimepiride definitely. فزي ما قلت احنا we try to avoid the glybenclamide. Glimepiride is not contraindicated بس it's not the best. إذا استخدمناه بنستخدم small doses وبنحاول avoid it at a GFR below 30 وبناخد بالنا قوي من الهايبوغلايسيميا. لو هتستخدم حاجه الجلايكوزايد للاسف بقى له فتره مش موجود في مصر، اللي هو الميني داياب. It's a short acting drug with a very low risk of hypoglycemia. ان ما كانش يبقى الجلايكوزايد ده اكتر حاجه النفرولوجيست بيحبوا يستخدموه في عيانينهم، لانه كمان متجرب في عيانين الدياليسيس. It's pretty safe. تستخدم دوز قد ايه؟ طبعا ببتدي من very small doses وتايتريت upwards. بنلاقي عيانين كتير جدا ماشيين على دوزز up to يمكن 120 ملغ واكثر كمان، وبيغسلوا very stable no hypoglycemia و this is acceptable. طبعا most patients will need only half the regular dose. طبعا عيان كل ما بيحصل كلى بتزيد كل ما بنقلل الدوز ونمونيتور. بس انا قصدي انه there is no upper limit as long as the patient is a compliant patient، بياخد الدواء بتاعه وبياكل وبيعمل proper follow up وما بيحصلوش hypoglycemia. Just titrate the drug upwards slowly carefully تحتيها 10 خطوط. وزي ما انا قايل فوق تاني اهو it's a love hate relationship. احنا ما بنحبش الادويه دي في عيانين الكلى، ولكن اذا اضطرينا carefully the answer is glyclazide. glyclazide مش موجود. الجليكيدون كان دخل مصر شويه وبعدين اختفى مش عارف راح فين. طيب which is the safest drug بقى من موضوع الهايبوغلايسيميا؟ احنا من ساعه ما قعدنا تقريبا بنتكلم عن الهايبوغلايسيميا. I think the answer is DPP-4 inhibitors. يعني they are the safest hypoglycemic drugs that we have. احنا شفنا دكتور محمد حسنين تفضل وقال قولوا لي ايه هو الدواء اللي سعره معقول. طبعا DPP-4 inhibitor يعني كان بيقول الاوبتيمم دراج بتاع السكر دواء سعره معقول. DPP-4 inhibitors يعني they are not the least من حيث الكوست، ولكن سعرها بقى quite affordable جدا يعني دلوقتي، لانها من الحاجات اللي ما زادتش في الفتره الاخيره. طيب وeffective. They are effective. They're not as potent as sulfonylureas, but they are very effective drugs. Weight neutral. They are weight neutral. ممكن I don't think they will help you lose weight, but they're weight neutral. And so they are quite ideal drugs في عيان الكلى. و they are very safe في عيانين الكلى up to dialysis. طبعا في drug dose adjustments. الفيلداجليبتين we have study عليه في عيانين الدياليسيس. We use 25 to 50 milligrams per day في العيانين دول. الحقيقه السيتاجليبتين كمان is quite safe in those patients. We do have studies عليه. They are both quite safe. We just use them at half to 25% of the usual dose. طيب لما بتيجي دايما سيره الدي بي بي 4 inhibitors نسمع على دواء اسمه ليناجليبتين اللي بينقذ العيانين من مشاكل الكلى. ليه؟ لانه ملوش رينال ادجستمنت. احنا كدكاتره كلى كلمه ملوش رينال ادجستمنت ما بت يعني ما بنحبهاش قوي يعني، لان احنا بنحس ان انا ايه الدواء اللي ليه رينال ادجستمنت if it is a safe drug. تاني لو انا بستخدم دواء سيف وليه رينال ادجستمنت ده حاجه بعتبرها ميزه، لاني بدي العيان جرعه اقل من الدواء فبكلفه فلوس اقل وبجيب الايفكت اللي انا عايزها. فلما تقول لي ان انا اقدر ادي العيان جرعه كامله من الدواء او نص الجرعه من دواء تاني والاثنين هيجيبوا نفس الافيكاسي ونفس السيفتي، اكيد هديله الدواء اللي فيه رينال ادجستمنت علشان اوفر عليه فلوس يعني. فحكايه الرينال ادجستمنت دي ما بتدخلش علينا قوي. طيب الحاجه الثانيه اصله بيبروتكت the kidneys. This is one of the biggest lies in medicine. الحقيقه the study that they have used mainly to promote this الدواء ده دواء study اسمها الكارميلينا study which is a study that was mainly designed علشان تشوف cardiovascular endpoints في عيانين السكر، وكان ليها secondary endpoint انها تشوف a secondary endpoint of end stage renal disease او reduction في GFR او renal death، والحقيقه لم يتمكنوا من تحقيق هذا السكندري endpoint. وكان عندهم 17 tertiary composite endpoint ثانيه including different levels of GFR و chronic kidney disease و death و proteinuria، ولم يتم تحقيق اي حاجه. يبقى دي 18 endpoint فشلوا في تحقيقها. وبعدين 15 endpoint اسمها single endpoints exploratory endpoints، كلها صحيح pre-specified ولكن كانت كلها exploratory endpoints، ولم يتمكنوا من تحقيق اي واحده فيهم ولا حتى انهم يقللوا البروتينوريا، اللهم الا انه يغير الكاتيجوري بتاعت البروتينوريا which is a very very funny definition للبروتينوريا. والحقيقه لو دخلنا في تفاصيلها انا مش عايز اضيع وقت بس كتير في الكلام على الدواء ده، بس I can tell you very safely that this is not the drug that can protect او prevent العيان من الكدني ديزيز. لان انا كتير قوي بشوف لما عيان بيبقى متابع معايا وليتس سي بياخد فيلدا او سيتا او وات ايفر جليبتين، وبعدين يروح لحد الاقيه راح شايله قال له ايه ده ازاي بتاع الكلى ما خدش باله كتب لك اللينا جليبتين. الحقيقه هو احنا لما بناخد بالنا بنشيله ما بنحطوش. فلينا جليبتين is just another DPP4 inhibitor. It is not the drug to use to prevent or treat chronic kidney disease. ربما يكون ليه a very very minimal disputable unconfirmed effect على البروتينوريا لمن يصر عن الدفاع عنه، ولكني لا ارى انه من الستادي بتاعت الكارميلينا دي يستحق انه يتكتب يعني. امال ايه الدواء بقى اللي احنا بنحبه اللي ساكن جوه قلب دكاتره الكلى ودكاتره السكر ودكاتره القلب؟ الميتفورمين. طبعا it's a drug that has been shown to reduce the endpoints بتاعت العيانين بتوع الدايابيتس macrovascular ومايكروفاسكولار وديث and so on. So its effect is independent of the blood sugar control وبيقلل المورتاليتي بتاعت العيانين بتاعت الكرونيك كيدني ديزيز specifically في الدايابيتيك كيدني ديزيز بيشنتس. طب ليه سمعته وحشه؟ سمعته وحشه بسبب اخوه الكبير اللي هو اسمه الفينفورمين. الفينفورمين ده الدواء اول بايجوانايت طلع وكان دواء بيعمل لاكتيك اسيدوزز، وهو اللي شنكل اخوه وقعه كده، وفضلت السمعه الوحشه ووصمه العار بتاعت الفينفورمين لازقه على الميتفورمين. هل الميتفورمين دواء بيعمل لاكتيك اسيدوزز؟ الحقيقه عايز اقول لا، بس مش هقول لا، هقول extremely rare. وهقول انه تقريبا كل الحالات almost all the cases of reported lactic acidosis toxicity في العيانين اللي بياخدوا ميتفورمين كان بيبقى عندهم another cause لللاكتيك acidosis. تعالوا نبص على الارقام علشان برضو احنا اصل انت لو ما اديتش ميتفورمين ما انت هتدي العيان ايه؟ لو عيان بياخد ميتفورمين ليتس سي ودي بي بي 4 انهبيتور ومفيش فايده، هتدي له ايه؟ يا سلفونايل يوريا يا انسولين في الغالب. تعالوا نتفرج على الميتفورمين. الميتفورمين اسوسييتد لاكتيك اسيدوزس بيحصل في 6 من كل 100,000 عيان في كل سنه. المورتاليتي ريت في دول هيبقى النص، يعني 3 من وسط ال 100,000 هيتوفوا، طبعا كتير. تعالوا نبص على الهايبوجلايسيميا. هايبوجلايسيميا الانسيدنس اوف هايبوجلايسيميا مع السلفونايل يورياز بقى لما نقارنهم باخواتهم السلفونايل يورياز الناس بتجري عليها، الهايبوجلايسيميا is about 1%، the mortality rate of about 4.3% من ال 1% دول، يعني هيموت حوالي 43 واحد من 100,000. Yes, من السيفير hypoglycemia. Yes, we see patients with chronic kidney disease with severe hypoglycemia all the time. But I have not really seen any patient with lactic acidosis مع الميتفورمين الا اذا كان دايما بيبقى فيه سبب ثاني. There is almost always سبب ثاني. كنت لسه بقول المحاضره دي في وسط مجموعه من النفرولوجيست، وحد قال لي وقال لي لا بقى انا شفتها في عيان لا كان عنده سبسس ولا عنده هايبوتنشن ولا كان عنده اي حاجه خالص، وخد ميتفورمين وبعديها بيومين جالنا المستشفى على الاي سي يو بلاكتيك اسيدوزز. قلت له ليه بس ازاي حصل الكلام ده؟ في الاخر بعد ما قعدت اجيب واودي فيه طلع ان هو عيان كانوا عارفين من الاول ان عنده فاميليال ميتوكوندريال ديزيز بيعمل لاكتيك اسيدوزز، وهم اللي ادوا له الميتفورمين. الحقيقه ميتفورمين لوحده كده يعمل هايبوجلايسيميا is almost unheard of، حاجه نادره جدا جدا جدا. وعلى فكره اللي عايز اقوله لكم بقى انه عيانين السكر عموما حوالي 6 من كل 100,000 بيجي لهم لاكتيك اسيدوزز اصلا من غير ما ياخدوا ميتفورمين every year. طب والانسولين؟ لا الانسولين بقى احتمالات انه يحصل سيفير فيتال هايبوجلايسيميا معاه ضعف السلفونايل يورياز. ميتفورمين is a very safe drug. طيب يجي السؤال اللي بعد كده بقى، اللي دايما إيه العيان يروح ويرجع يقول لي رحت لحد وقال لي الميتفورمين ده انا هوقفه لك، ما اعرفش ازاي دكتور الكلى كاتبه لك، ده نيفروتوكسيك. الحقيقه اسمه نيفروتوكسيك. ميتفورمين ما اعرفش شفتوا الفيلم ده ولا لا، لما كان الليمبي مصر يقول لعم بخ انت بابا مات، ابوك مات مقتول ازاي يا عم بخ؟ قال له 100 مره ابويا ما ماتش مقتول يا ليمبي. ميتفورمين والله العظيم is not a nephrotoxic drug. It is not a nephrotoxic drug. طيب هل معنى كده انه it is an extremely safe drug؟ Nothing is extremely safe. Nothing is perfect. الحقيقه انه ليه دوز ادجستمنتس. لو هنبص على الجايد لاينز وهنمشي جنب الحيطه، الجايد لاينز اخيرا الحمد لله يعني رضيت علينا، وبعد ما كانت بتقول كرياتينين 1.3 اقصى حاجه، بقت دلوقتي بتقول جي اف ار 30. لكن لو عايزين نبص بقى على الريال داتا بقى اللي موجوده في الستاديز اللي موجوده عندنا في الجورنالز بتاعت النفرولوجي بقى لها 100 سنه، وكل يوم we get more and more and more and more new studies. It is safe up to a GFR of 15. It's even safe in patients on dialysis. We do not use it في عيانين الغسيل، بس عايز اقول لكم انه الحقيقه في داتا انه it is safe. ولكن بعد ما يتعمل دوز ادجستمنت طبعا. فالمهم يعني لو العيان الجي اف ار بتاعه اكتر من 45 بندي جرام ونص ماكسيموم، اكتر من 30 اقل من 30 عفوا لغايه 30 ممكن جرام، من 15 ل 30 الجي اف ار بنستخدم 500 مللي جرام بس. If you are not going to be one of those who like to stick to the guidelines, and if you like to look at more evidence عن المكتوب في guidelines, you can go down to a GFR of 15. Below 15 I would not suggest that it be used، على الرغم من ان في شويه داتا بتقول ان it is safe عينين البي دي والهيموداياليسيس. ما بقولش نستخدمه، لكن بقول انها لو شفت حد كاتبه العيان غسيل بدوز 250، ده مش دكتور مجرم، ده دكتور في الغالب فاهم وقاري يعني. طبعا لما عيان يبقى بياخد ميتفورمين ويجي له سبسس او يخش الاي سي يو، اتس فيري وايز تو ستوب ات، لان ده كده بيزود جدا الريسك فعلا انه يجي له سيريس لاكتيك اسيدوسيس. طيب في دواء جديد بقى، اختراع جديد جميل جدا جدا يعني، مبسوطين احنا منه جدا في النفرولوجي كوميونتي، وي ار فيري اكستاتيك اباوت ات، اسمه الاس جي تي 2 انهبيتورز. الحقيقه دي ادويه جديده حضراتكم عارفينها طبعا، شفنا بيها فيري يوسفول هارد وانترميديت اند بوينتس في عينين الكلى، والسيفتي بروفايل بتاعها is quite reassuring. مش هنتكلم على فائدتها في عيانين القلب وفي الهارت فيلير and so on، ولكن الحقيقه it has shown those drugs، يعني دي داتا من الديكلير ستادي مثلا على استخدام الداباجليفلوزين. It reduces the composite endpoint of reduction of GFR وdeath و end stage renal disease، اللي لو تفتكروا اللي نجلبتن ما قدرش يعملها. الحقيقه it reduces كمان الجي اف ار الاند بوينت بتاع انه يحصل ريدكشن في الجي اف ار او end stage renal disease او renal death. والحقيقه every single end point اي حاجه هتدور عليها مع ال SGLT2 inhibitor في عيان كلى almost always هتلاقيها بتتحقق، مش بس مع الدافاجليفلوزين، لكن الحقيقه طبعا مع كمان الكانا ومع الامباجليفلوزين. الجميل بس في الصوره دي اللي انا حاططها انها بتوري انه غالبا العيانين اللي بيستفيدوا من الدي بي بي من الاس جي ال تي 2 انهبيتورز في انه يقلل البروجريشن اوف كيدني ديزيز هم العيانين عندهم بروتينوريا. وعلى فكره اغلب الستاديز دي كان العيانين بياخدوا الماكسيمم تولربل دوز من الاي سي انهبيتور او انجيوتنسين ريسبتور بلوكر. It's a drug to be used for nephroprotection on top of الراس بلوكر. طيب لما بتكلم مع اصدقائي دكاتره السكر بلاقيهم بيزعلوا قوي لما بكتب الدواء ده، يقولوا لي ده دواء خيبان ما بيقللش السكر، ولو كتبته العيان انا هوقفه لانه انا عايز اظبط السكر وانت حاطط لي دواء ما بيظبطش السكر. الحقيقه انه هو فعلا في العيانين اللي عندهم كيدني ديزيز كل ما الجي اف ار بيقل كل ما الافيكاسي بتاعته بتقل. السيفتي اتس ا سيف دراج، الافيكاسي بتقل، بس انا مش بكتبه as an anti-diabetic drug. I'm going to say it again, we are now using it as a drug for the kidneys even in non-diabetic patients، لان الداتا اللي طالعه في non-diabetic patients with kidney disease مع الادويه دي is very reassuring. والحقيقه انه الداتا اللي طالعه من الكريدنس ستادي ومن الداتا سي تي دي ستادي is quite it shows انه الدراج is still effective في النفرو بروتكشن والكارديو بروتكشن كمان. الحقيقه حتى لما الجي اف ار بيقل تحت 30. فالكلام القديم بتاع ما تكتبوش الا لو الجي اف ار فوق 45 ده كلام قدم الحقيقه. لا، هو احنا بنستخدمه لما الجي اف ار يكون فوق 30 وبنكمل بيه لغايه لما يوصل ل 15 او even up to dialysis. They're very 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 safe, very they seem to be very useful drugs from a nephroprotective point of view. نمرة 11 الجي ال بي 1 receptor agonists في chronic kidney disease. They are all usable. Some of them need drug dose adjustment. الليراجلوتايد بالذات كان cardioprotective او بيقلل الاثيروسكليروتيك كاردياك ديزيز في العيانين اللي عندهم kidney disease كمان، يعني diabetics with kidney disease. ف it's probably the drug of choice if you're going to use those drugs في عيانين الكلى. اخيرا، امتى النفرولوجيست عايز يشوف بقى عيان السكر اللي عنده مشاكل في الكلى؟ الحقيقه لو هيتعمل له العيان، احنا بنبقى عايزين العيان كنفرولوجيست يبقى مع الدايبيتولوجيست بتاعه، لانه هو اللي هيقدر يمانج الاوتكمز والجلايسيميا بشكل احسن. ولكن بنبقى دايما عمالين بنلح على الدكاتره في البرايمري كير والانترنست، بليز 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 check the GFR and the albuminuria كل سنه على الاقل للعيان بتاعك، ولو سليمه قيسها تاني حتى لو العيان ما عندوش diabetic retinopathy، وحتى لو العيان ما عندوش اديمه في رجليه. ملهاش دعوه خالص، مش لازم، يعني مش لازم نستنى البلا لما يحصل، يعني let us check it قبل ما البلا قبل موضوعه. ولو لقيت عند العيان اي حاجه ما تبعتهوليش، مش هعمل له اي حاجه اكتر من اللي حضرتك بتعملها الا لما الجي اف ار بتاعه يقل عن 30، لانه لما بيقل عن 30 بيبتدي يحصل اسيدوزس بقى، وبيبتدي يحصل مشاكل سي تي دي ام بي دي وانيميا والثينجز ذات ار نوت جاست تريتد بقرصين كالسيمات وقرص 1 الفا زي ما نشوف ناس كتيره بتعمل. it becomes a long story that does need co-management الحقيقه with a nephrologist. You will also need to co-manage with a nephrologist when البروتينوريا is او البلاد بريشر او الريت اوف تشينج بتاع الجي اف ار كرياتين عمال بيعلى، او في هيماتوريا او كاست او الزلال اوت اوف بروبورشن، الضغط اوت اوف بروبورشن، الامور شكلها مش مريح يعني زي ما بيقول. وبالتالي علشان نعمل هدنه مع الدكتور اللي كان زعلان مني قوي 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 في الاول، اللي كان عشان عايز اكتب ميتفورمين لعيانين الكلى، يعني خلينا نقول انه ميتفورمين از ذا كينج. ميتفورمين هو الدواء الملك لغايه دلوقتي في العيانين الدايابيتكس اغلبهم، as long as it is being used wisely, with proper adjustment, with proper monitoring of the kidney functions, with proper كل حاجه. Everything has to be done wisely. Anything used unwisely is not going to be good. طبعا SGLT2 inhibitors هو الملكه بقى اللي جايه مع الملك، يعني they are the new drugs. GLP receptor agonists are also probably useful drugs عشان الاوتكمز بتاعتها في الكارديوفاسكولار اوتكمز، انما الدواء الاساسي والايدي العامله يعني اللي بنعتمد عليها في هذه المعاهده بالشعب بتاعنا يعني هو الدي بي 4 inhibitors. It's the drug that is safe and effective، لانه غالبا ميتفورمين لوحده مش هيظبط، يعني غالبا احنا بنبتدي بميتفورمين غالبا مش هيظبط لوحده، وبيحتاج مع الدي بي 4 inhibitors هم الاساس في كنترول اوف ذا جلايسيميا. سلفونايل يورياز هنسيب المواطنين السلفونايل يورياز يعيشوا تحت الملاحظه الشديده جدا مع اعتبارهم خونه ممكن يعملوا مشاكل في اي وقت. وطبعا ليناجليبتين is just another DPP4 inhibitor. Please do not use it as a drug that saves the kidney because it is not. Thank you very much.
شكرا ليك دكتور محمد، ودايما موضوع الكدني بيعمل أسئلة كتيرة الحقيقة. حضرتك جاوبت على جزء كبير منها. طيب احنا في سؤال عن الدوز of metformin in hemodialysis patients.
الميتفورمين في عيانين الغسيل، بصي هقول لحضرتك على حاجه يا دكتوره ايناس، يعني علشان هو الاجابه لا. ميتفورمين في عيانين الغسيل الاجابه لا، لانه والا يعني في داتا انه it is safe at a dose of 250 milligrams. في داتا كتيره انه it is safe في عيانين الغسيل at a dose of 250 milligrams per day. ولكن يعني مش عارف هقولها بطريقه بلدي شويه، يعني ما حبكتش يعني ما يعني طيب بس لحد الغسيل وقف لحد GFR 15 وكفايه يعني. انما الحقيقه ان انا لو شفت حد كاتبه العيان غسيل ببروبر دوز وشايف انه العيان مش حاصل له مشاكل وشايف انه الدكتور بتاعه عارف هو بيعمل ايه وجالي العيان ده for second opinion، انا هقول له خليك ماشي على الدواء. You can use it at a dose of 250 milligrams in dialysis patients, but I strongly suggest that it be stopped at a GFR of 15.
طيب في سؤال تاني، is novonorm safe in CKG؟
Yes, it's هو شبه السلفونايل يورياز الشورت اكتنج. يعني it's an efficient drug, it's short acting والهايبوغلايسيميا معاه قليله، وبالتالي yes we can use it. yes.
طيب هو الحقيقه ان في اسئله كتيره للدكتور محمد حسنين، بس احنا الدكتور محمد عندهم في دبي الوقت ساعتين زياده، فهم عندهم قربت يعني بعد منتصف الليل. في سؤال على التارجت هيموجلوبين A1C with hemodialysis.
ما هو احنا قلنا يا دكتوره ايناس ان هو عيان الهيموداياليسيس بس مشكلته انه very prone للهايبوغلايسيميا، ومشكلته الثانيه انه الجلايكيتد هيموجلوبين is a very inaccurate measure of glycemia control في العيانين دول، وبالتالي يعني احنا بنقبل a level of around 7 to 8. زي ما شفت الستاديز اغلبها المورتاليتي بتبقى اقل في الرينج بتاع 6.5 ل 8.5، بس يعني 7 to 8 is...
طيب سؤال تاني، CKG patients on hemodialysis which group of oral anti-diabetic drugs to start with؟
ارجع تاني زي ما حضرتك قلنا
CKG patient سؤال
زي ما حضرتك قلت كل ما العيان يكون اصغر في السن، كل ما هبقى عايز امشي ناحيه ناحيه more strict كنترول للجلوكوز حتى لو هو عيان غسيل. ولكن تاني هرجع واقول عيانين الغسيل are very prone لهايبوغلايسيميا، فusually 7 to 8 is what most of us would accept، الا لو كان العيان كبير قوي في السن وفريل ولايبل انه يقع يجيله fractures، بنميل ناحيه ال 8 وال 8.5. مشكله عيان الغسيل انه they are very 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 prone ان هم يجي لهم هايبوغلايسيميا، وان يجي لهم فولز، وان يجي لهم fractures و they are fatal لما بيتكسروا. فيعني الخلاصه انه الرقم is around 7 to 8 اقرب لل8 في العيانين الكبار يعني.
CKG patient on hemodialysis, which group of oral anti-diabetic drugs to start with؟
DPP-4 inhibitors. يعني this is the easiest question. DPP-4
on hemodialysis.
Yes, DPP-4
بس يتظبط لهم الدوز يا دكتور محمد؟
Yes طبعا بعد ما يعمل دوز ادجستمنت. بعد دوز ادجستمنت الفيلداجليبتين الدوز بتاعته is 25 to 50 ملغ، والسيتاجليبتين is 25 to 50 برضه في عيانين الغسيل. يس.
طيب احنا طبعا بنشكر حضرتك جدا. هو في اسئله كتير وفي اسئله كمان للدكتور محمد واسئله ليا، ولكن طبعا احنا لسه عندنا محاضره هنسعد بيها جدا مع الاستاذه الدكتوره جميله نصر. الاستاذه الدكتوره جميله نصر is professor of cardiology Suez Canal University, General Secretary of the Egyptian Society of Cardiology, President of the Preventive Working Group Africa, Vascular Disease Prevention. Professor جميلة منورانا النهارده. Very eminent lady cardiology ومحبوبة من الجميع، لازم أقول الكلام ده. حضرتك منورانا.
أنا متشكرة لحضرتك جدا، ودايما ببقى سعيدة جدا تشير مع حضرتك، والحقيقة كل بيبقى فيه يعني ميتنج بتكوني حضرتك عاملاها بنكون متأكدين إنها ناجحة وإليجنت كمان. يعني احنا هنتكلم النهارده على الكاردياك ريسك ان دايابيتكس، ويعني احنا هنتكلم على حاجات بسيطه جدا. اني يعني لما بنقول على cardiovascular disease and diabetes the following statistics speak loud. طبعا في strong correlation between cardiovascular disease and diabetes. At least 68% of people of age 65 or years or older with diabetes die from a form of heart disease. 16% die of stroke. It is adults with diabetes are 2 to 4 times more likely to die from heart disease than those without diabetes. And of course, the American Heart Association considers diabetes to be one of the major controllable risk factors for cardiovascular disease. What about the Egyptian males patients? And we have 47% of Egyptian male patients and 69 patients of female presented with acute coronary syndrome are considered premature atherosclerosis. So in the Egyptian population, we're facing a really big problem that our patients are much younger, and this we have to consider very much. And still we do have in another study that we do not have achievable goals like for some dyslipidemias and other factors. We know that the total deaths from cardiovascular disease in Egyptians, the non-communicable diseases are estimated to account for 85% of total deaths, and still the ischemic heart disease is #1 killer, both in men and females. What about glycemic control? Evolution over time. Actually, in the year 2000, before 2008, hemoglobin 1C was the lower the better. But after that, in this year, it said that the lower the better, but without weight gain and hypoglycemia and side effects. What about 2018 and more? They consider the managed total cardiovascular risk by including glucose control with agents of proven safety and preventive efficacy. So the preventive strategy has become a very important item. You can see what is diabetes. As all know, that is a chronic condition that's characterized by raised blood glucose levels, hyperglycemia. But if you think about cardiologists, maybe we have a different definition. It's just to say type 2 diabetes is a condition of premature cardiovascular complications in the setting of chronic hyperglycemia. This may be considered a definition for the cardiologist. Of course, the world is a huge growing problem, and the cost to society is very high and escalating. And maybe by the year 2035, maybe this number will rise to more than 592 million, which is really a big problem. And we should think of that very important. What about the Mr. Fit impact of diabetes on cardiovascular mortality? You can see the huge difference between diabetics and the non-diabetics. The number of risk factors, again, is very important to be considered for the difference between the diabetics and the non-diabetics. So cardiovascular disease is responsible for 80% of mortality in diabetic patients. And what about the UKPD studies findings? Of course, it's risk reduction with 1% decline in annual mean. If you have really, it decreases the microvascular disease, it decreases the peripheral vascular disease, the MI, the stroke, the heart failure, and the cataract as well. So we have to think of that, very important. Again, the United Kingdom prospective diabetes study, it was found that if the hemoglobin 1C, there occurred 2,000 events. If it is less than 6%, actually, we had around 2.3 heart failure events per 100 person per year. But if it is more than 10%, it may be it's extremely much more, and accounting for 11.9 heart failure events per 100 persons per year. So this is very important. And we have, of course, many resources for diabetes. Decades of study have defined numerous potential factors that each contribute to the disease susceptibility progression, and we should look for that. So we do have different stages, different phenotypes, different treatments for different factors. And of course, it is a really independent factor for heart disease. Two-thirds of patients with established cardiovascular disease have impaired glucose hemostasis. It affects 30% of heart failure patients. Of course, that we know every 1% increase in the glycosylated hemoglobin leads to an 8% increase in heart failure. This is very alarming. And the prevalence of heart failure in general population, 1.4 and 1 to 4%, and diabetics, it's 15%. So we have to look how it is enormously, decreasing the mortality in the general population. What about in diabetes? If we are talking about cardiovascular disease in diabetes, we do have some different aspects for the coronary vessels, endothelial dysfunction, the increased arterial stiffness, the calcification of the coronaries, the accelerated atherosclerosis, and also there is an impact on autonomic nervous system with reduced heart rate variability, increased resting heart rate, which is very alarming, arrhythmia, impaired coronary vasomotor capacity and the cardiac muscle, leading to diastolic dysfunction, systolic dysfunction. So we have different aspects of impact. All this dilemma of diabetes, hyperglycemia, it at the end leads to our very alarming complication of heart failure. What about the diabetic cardiomyopathy? And we'll talk about it is a distinct entity characterized by the presence of abnormal myocardial performance or structure in the absence of epicardial coronary blood disease. And actually, this is very important. It's a cardiac diabetic cardiomyopathy is a cardiac dysfunction which affects approximately 15% of diabetic patients, leading to overt heart failure and sudden death. How diabetes contribute to myocardial dysfunction in particular? Actually, we do have molecular substrate in diabetes. It causes hyperglycemia, significant functional alteration to the cellular sodium-calcium ionic channel. It decreases the extrapolation and increased intracellular concentration of ionic calcium. It actually leads to dysfunction of cellular sodium-potassium channel, increase in the sodium, intracellular sodium, and increase intracellular calcium in cardiac myocytes. So can we see it's really the diabetic cardiomyopathy is a mild myocardial interstitial fibrosis stained in blue and mesenteric from white arrow in a patient with long-standing duration type 2 diabetes at autopsy with perivascular fibrosis. Of course, also we have the gene expression. As we can see, there is enhanced myocardial gene expression for muscle carnitine, and we have down regulation. So it's actually the gene expression is encountered in patients having diabetic cardiomyopathy. Maybe there is some anatomical damage of the myocardial substrate. Maybe this atheroma, more extensive, more diffuse, pathologic alteration of small coronary vessels and myocardial endothelium, including increased cell adhesiveness, and impaired relaxation. So we do have really different mechanisms. The hyperglycemia, free fatty acids, the insulin resistance, and all these lead to vasoconstriction, inflammation, thrombosis, which all diabetic hyperglycemia, hyperlipidemia, inflammatory cytokines, all these lead to abnormal metabolism, to glycated end products, and all these lead to many abnormalities for apoptosis, for cardiac dyshemostasis, the lipotoxicity, and so all these are leading to abolished preconditioning, which is very important for the cardiac muscle, cardiovascular autonomic neuropathy, beta adrenergic signaling pathway dysfunction, and many other abnormalities. These are the hidden mechanism of diabetic cardiomyopathy. We do have altered insulin signaling for having many pathophysiologic aspects as well. Diabetic cardiomyopathy is a consequence of metabolic disorders, and all these lead to hypertrophy and dilatation, and this leads to systolic dysfunction, and the ending, unfortunately, to fibrosis with lipotoxicity and loss of the cardiac cells, which is really very alarming. Phenotyping is very important, and it is different in the restrictive versus the dilated phenotype. So we do have phenotype differences in diabetes. How to diagnose this early cardiac dysfunction in preclinical settings? It is not an efficient or easy task to detect the preclinical detection, which is very important methodology. But we do have why? Because molecular mechanisms are not fully elucidated. It remains asymptomatic for many years. It has comorbidities frequently coexist. So how can we diagnose? Diagnosis of currently diabetic cardiomyopathy by exclusion of known risk factors for heart failure. So physicians actually should rule out the other potential cause of symptoms. The underlying specific pathophysiologic mechanism are, however, is really unknown. Could look for screening for asymptomatic patients, look for the routine cardiovascular screening is not recommended, and treatment of risk factors is the focus. Look for the overt cardiovascular disease, can consider some drugs, we can consider ACE, we can use aspirin, we can use statin, you can use maybe beta blockers and metformin, again, as we can see of actually in a stable heart failure, we may use metformin in the presence of normal and avoid metformin in unstable patients. The clinical context of these patients, depending upon the duration of diabetes, exclusion of cardiovascular disease, hypertension, and the glycosylated hemoglobin, other risk factors, patient age as well. We do have actually cardiovascular risk factors, which is specific for diabetes. It is very important to the cardiologist. This is the microalbuminuria, the massive proteinuria, the abnormal platelet function, the fibrinogen levels, the serum insulin, the thrombosis ability, and actually you can do resting ECG. We can do stress ECG if it can detect the resting ECG can detect sinus tachycardia. Look for the QT length interval. Look for the altered heart rate variability. Look for the QT variability, because if you are looking for the QT variability, this means that your myocardium is unstable, and the patient may develop some premature ventricular ectopics. Look for the exercise testing. Look for the cardiac autonomic function analysis. Look for the resting heart rate. Screen for silent ischemia by stress ECG, resting ECG, stress testing, perfusion imaging, and this is the patient actually having some important basal left ventricular hypertrophy. And we can use a dimensional echocardiography, which is shown to increase the wall thickness and left ventricular hypertrophy even in pre-diabetic stages, and look for the diastolic functional changes by echo is very important as well. And look for the diastolic dysfunction, which is found in 40 to 75% in diabetic patients, which is very important. We can use the advanced techniques for echocardiography, maybe the tissue Doppler analysis. We can look for the EA ratio. So we do have many parameters. many advanced echo techniques for the diastolic dysfunction. We can look for the presence and severity of diastolic dysfunction, and we can use many techniques. Actually, it was found that in these patients, if you look at that echo, and we have even some mitral valve affection with valvular diseases, it's actually present in 32%, and it increases the mortality. So this is very important. And as we can see that because the left ventricle becomes more spherical, and as we can see, this is a form of mitral regurg, which is found, and it indicates significant diastolic dysfunction. We can look for the new advanced techniques, strain, the reduced myocardial strain. Maybe there was, we conducted a study looking for the preclinical, in the pre-diabetes, we found that there is some perfusion defects indicating ischemic changes in those patients having ischemic heart disease, and we can see that there is perfusion defects in these patients, which is very important. What about the guidelines? 2019, it showed that there is risk-enhancing factors for clinician-patient risk discussion. One of them is the metabolic syndrome, which is one of its more important items of it is the increased waist circumference and actually the triglycerides and the elevated glucose as well. We have to spot upon prevention and look for the sum of the physical, some risk factors for developing the luckily we have the risk factors for all chronic diseases are all the same. And one of this important is there's no physical activity, and actually in Egypt it is considered one of those nations in the Arabian countries to have low physical activity, which should be considered very important. So very interesting slide. That there is a subway ticket machine in Moscow accepts the 30 squats as its payment. So exercise is important as an important way to improve and preventive tool. This is an excellent way of using technology. It's a good use of technology. On the other hand, in the pizza, this is a poor use of technology. So please, you should shorten time, get active 10 minutes 3 times a day for prevention. Look, physical activity and diet are important regardless of weight. So should attain a desirable weight isn't enough to be healthy. So we have to look for the physical activity as well as diet. Obesity and life expectancy is really important in Framingham study, and we found that the obese smoker lives 14 years less than normal. The obese at 40 years lives 6 to 7 years than normal. And of course, we have to adopt an exercise, based program, and we can, for example, tell your patient to take stairs. This will take around 19 calories to be burned, and not use the lift, which just consumes only 3 calories per half an hour. Tell your lady, the wife to cook the meal for in the house. This will consume around 70 calories, where order takeaway, it just will consume 1 calorie. Please, you should move more and more. This will prevent all the chronic diseases in diabetes, in ischemic heart disease patients. Avoid the sofa. The sofa, please. This is solid fats, added sugars, which is very important. So the healthcare system, the iceberg phenomena, the self-care, we can prevent 80% of the problem. And before trying to get the professional care, which is actually 20% for the primary, for the secondary, for the tertiary, and before we can see that is the future of prevention. That is, of course, the lifestyle changes. There will be the drug therapy. take care that the drug therapy, there is a future innovating targets in different aspects for the hypertension, the hyperglycemia, the dyslipidemia, maybe have the to improve. This is the preventive based strategy in patients in type 2 diabetes, in cardiovascular events. What about the COVID-19 era effects of hypertension, diabetes, and coronary heart disease? All say that the conclusion, this is the meta-analysis conducted, maybe few days ago, and it showed that the hypertension, diabetes, and coronary disease can affect the severity of COVID-19. It is related to the imbalance of converting enzymes and the cytokine storm induced by the metabolic disorders. Do we need a change? Yes, we have to establish a culture of healthy living. We have to set the goals for the sustainable development goals, where the keeping health is number 3. We have to adopt this very nice equation of the European Society of Cardiology for prevention. This is in a formula equation, 035140530. What does that mean? 0 stands for no tobacco. You should walk 3 kilometers a day or 30 minutes, any moderate activity. You have to take 5 portions of fruits and vegetables. You have to, of course, if he's diabetic, we should take care of that, to take not a big amount of fruits, and blood pressure should be less than 140. 5-3 stands for the dyslipidemias. 0 stands for avoidance of overweight and overweight and obesity and diabetes. So diabetes here is integrated in the equation of the European Society of Cardiology as a real important risk factors. So the end is the greatest wealth is health, and this is, we need all, according to the Maslow's hierarchy of needs, to be able to achieve, to be responsible, and we hoping the best for our country. And thank you very much.
بروفيسور جميلة، حضرتك طبعا شرفتينا وشكرا المحاضرة.
أنا بشكر حضرتك جدا والله، ويعني اديتينا الفرصة الجميلة إن احنا نكون مع حضرتك دايما.
ميرسي فندم، متشكرين.
احنا بنشكر حضرتك على النجاح الكبير للميتنج ده، وان شاء الله يعني نتمنى دايما لحضرتك التوفيق في كل ايفنت حضرتك بتعمليه.
ميرسي فندم. هو طبعا يمكن عدد الحضور النهارده غير مسبوق بسبب طبعا وجود حضراتكم. احنا عندنا النهارده اكتر من 420، ده كان اخر رقم اتبلغته، يمكن يكونوا زادوا دلوقتي. الأسئلة داخلة في بعض، مش عارفة ليه في ناس. طيب في سؤال بقى مهم قوي بالنسبة لوجود حضرتك كقامة كارديولوجي كبيرة. أخبار الاس جي ال تي 2 ايه؟ هل حضراتكم ابتديتوا تكتبوه؟ في سؤال عليه، هل حضراتكم ابتديتوا تكتبوه في non diabetic patients ولا لأ؟ وهل البيشنتس، ده السؤال اللي هو 60 years old safety، أخبار حضرتك يعني هل من الحاجات اللي تقدري تكتبيها دلوقتي من غير diabetes، وهل حضرتك تقدري تكتبيها ل 60 years
of complications؟ فاحنا لكن already الحقيقة كأن هي تبقى approved في non-diabetic patients. It's still we are awaiting the maybe the recommendations, the guidelines ان هي تبقى تستخدم كأنتي فيلير by per se. لكن we hope ان الفترة الجاية ان هي تبقى used ان شاء الله، لانها it proved efficacy الحقيقة.
تمام. طيب احنا هنا
احنا طبعا العيان الدايابيتك مشكلته طبعا زي ما احنا عارفين كلنا انه مشكلته ان هو ما بيبقاش بيجي بسيمتومز، جاست المين برزنتيشن بتاعه بيبقى جاست ديسنيا. فطبعا في بيشنتس كتيره جدا بتبقى العيان ده بيحتاج اجريسيف تريتمنت، بيحتاج ان احنا بندي، لو هنستخدم ستنس بنستخدم دراج لوتنج ستنس، بنستخدم بيحتاج aggressive form of treatment بتبقى costly. ف if we can prevent the occurrence of complications this will be a breakthrough.
في سؤال: Is there any special treatment for COVID-19 in cardiac diabetic patient?
Actually in diabetic patients in COVID-19 كان في كلام ان احنا في problem with the ACE inhibitors واتكلم عليها كتير، وبعدين الحقيقة دلوقتي لا، الستادي الميتا اناليسيس اثبتت it is rather safe and may even have a protective impact. لكن sure ان احنا in COVID-19 patients لازم ندي العلاج بتاع العيان، ولازم to be kept on his medications. نخلي بالنا ان في complications new oral anticoagulation is very important. والحقيقه الاسبكت بتاع النواك دلوقتي او new oral anticoagulation is really considered. وmaybe ان احنا in some of these patients who are prone to develop embolic manifestations في ال COVID-19 patients, we need to new oral anticoagulants maybe for 1 month, and some studies recommendations say that we can even need for 3 months to give the NOAC even after the patient is fine and he's is the COVID-19 era, after going home. So I think that also patients with COVID-19 encountered a very important form of myocarditis, failure of the heart muscle. You can find this dysfunction, it's systolic dysfunction, diastolic dysfunction in those patients. All we have to say, just to keep on in patients in medications. You can use his medications. It's very important to treat blood pressure. It's very important to give the new oral anticoagulations in many situations.
خليني في الآخر أشكر حضراتكم جدا، إحنا سهرناكم. بشكر الأودينس. Thank you very much. Thank you for Novartis, the sponsoring company. طبعا بشكر الأساتذة الأفاضل Professor France from Denmark, Professor محمد حسنين from Dubai, Professor Jamila Nasr, eminent cardiologist in Egypt, Professor Mohammed Nasrallah زميلي, Professor of Nephrology in Cairo University. طبعا بشكر بيور سبوت. خليني أفكر حضراتكم إن بكرة في يوم تاني قوي جدا ومحاضرات جديدة، ونحب إن حضراتكم كلكم تبقوا متواجدين. هنبتدي بكرة الساعة 8 إن شاء الله، في انتظاركم.
يا خبر، سكر ده جالي منين ده؟ اعمل ايه بس واتصرف ازاي؟ وايه دي كمان؟ سحرة ملية؟ ده اللي جابها هنا دي؟ ايه ده؟ انا بتسحب. لا، اسمع كويس يا بدري وشوف لقطات من مستقبلك يمكن تتعلم، وركز في قرارك اللي هيحدد شكل حياتك. ده هيبقى شكل حياتك مع مرض السكر. ما تخافش، افتكر انك ممكن تصلح كل ده دلوقتي قبل ما يفوت الاوان. اول مشكلة هتقابلك اهي. شايف شكل عينيك عامل ازاي؟ يا لطيف، ايه اللي عينيا دي اهم حاجة فيا. وكمان كليتك، شايف شكلها وصل لايه؟ يا ستير يا رب، لا مش كليتي كمان، حتى اطرافك يا بدري. شايف بقى صعب عليك حاجات كتير كنت بتعملها في يومك. ايه انت بتقول ايه؟ يعني قصدك عمري ما هعرف ده غير رجلك اللي ممكن توصل لا قدر الله لكده. لا 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 لا، انا خارج من هنا، مش هقدر اسمع تاني. استنى بس، جه الوقت اللي تشوف فيه حياتك الإيجابية اللي هتبقى حقيقية لو اتعالجت بدري. اطلع السلم من هنا وشوف دنيتك هتبقى ازاي. يا فرج الله، أخيراً هتحافظ على عينيك ونظرك هيفضل سليم. أيوة يا سيدي قول كمان. أما كليتك هتفضل زي ما هي سليمة وزي الفل. يا سلام، مفيش أحلى من كده. وأطرافك كمان، يعني هتعمل كل اللي انت عايزه. أيوة كده طمنتني، وهتقدر تتمرن براحتك وتجري برجلين سليمة وقوية. أنا جاهز أبدأ حالاً. فعلاً ابدأ حالاً قبل ما يفوت الأوان. ياه، ده المستقبل شايل لي حاجات كتير، ممكن تبقى كويسة أو ممكن تبقى صعبة، بس خلاص أنا اتعلمت الدرس وعرفت أنا محتاج أعمل إيه. مساء الخير يا دكتور، لو سمحت كنت عايز الدواء ده، أصلا أنا قررت أبدأ بدري وغير حياتي للأحسن، وهو ده الوقت المناسب.
ممنوع تاخد أجازة، ما ينفعش تشتغل من البيت، ممنوع تعزل نفسك، مطلوب منك تختلط بالمرضى، تستنى الخطر في كل لحظة. لكل طبيب في مصر والعالم بيخاطر بسلامته وأمانه علشان حياة ملايين بيواجهوا خطر وباء كوفيد-19. كلمة شكرا مش كفاية. احنا في نوفارتس مش بس بنشكركم، احنا معاكم، بنشارككم ونشارك العالم كله بإسهاماتنا في جهود مكافحة كوفيد-19 عشان ننفذ التزامنا الدائم بتمكين ودعم المرضى. مش احنا بس، كل فرد في العالم بيدعمكم عشان تنجزوا مهمتكم. كل واحد قرر يشتغل من البيت، كل واحد بيحمي نفسه وغيره بالعزل الاختياري، كل واحد بيتجنب الاختلاط، كل واحد بيبعد عن أي مصدر خطر ولو محتمل، كل واحد بيحافظ على العادات الصحية. كل دول بيدعموكم وبيشكروكم وبيتمنوا لكم السلامة.